All right, I think it's time that we start. Welcome everyone to what is the third day of the Dauphine Digital Days. This morning we're going to talk about digital health. The theme of this morning is evaluation and regulation of digital health services. And I think we have a very exciting program lined up over the next 3 hours. Just to briefly introduce myself, I'm Peter Eibich. I'm organizing this session. When I'm not organizing this session, I'm a professor of economics here at Université Paris Dauphine. And I'm also a health economist although my work doesn't really focus on digital health, so I'm also looking forward to learning from the experts this morning. We start with 2 keynote addresses. I'll introduce the first speaker shortly. These are scheduled for about 45 minutes, including questions from the audience. And then at around 10:30, we have a coffee break. You probably might have seen that we have coffee, water, and pastries available outside. And then we reconvene at 11 for the roundtable discussion. Just a final bit of housekeeping. So this session is going to be primarily in English. This said, one of the keynote addresses will be in French. We have a team of translators available that is going to help us this morning. They're going to translate from English to French, and they're going to also offer translation from French to English. If, like me, you're not that comfortable speaking either of these languages, or speaking one of these languages, you can get one of these headsets, which are just in the entrance room, and these will allow you to follow the translation. So with this out of the way, I would like to introduce our first speaker this morning. The first keynote will be delivered by Professor Erik Koffijberg. Here, Erik is Professor of Health Technology Assessment at the University of Twente. He has extensive experience working on digital health technologies, so we're excited to hear from Erik today about his work on trying to evaluate the value of digital health technologies.
Thank you, Peter. I'm going to stand up because it's just easier to present standing up, I think. At least for me it is. Thank you for inviting me to talk at this Digital Days on this particular topic of technology assessment for digital health technologies. See if this is already on. Not yet. Otherwise, I can also just click on. Perfect. Sorry. Thank you. So I don't have any conflicts of interest for this talk. And let me start by just mentioning that I think in Western European countries with modern healthcare systems, we really face the same challenges in all of those countries when it comes to sustainability of our healthcare systems. So these are some graphs from the Netherlands. I don't have the corresponding graphs for France, but I'm guessing they look similar. So what you see here on the top is the expected increase in healthcare expenditure up to 2060. And as you can see, there's a prediction of an exponential increase in costs. What you also see at the bottom is the proportion of our workforce in the Netherlands that should work within healthcare if we don't radically change the way we organize healthcare. Currently, 1 in 6 is working in healthcare, but in 2060, without any changes, that needs to be 1 in 3. And you can imagine that this increase in costs, but also this amount of people needing to work in healthcare is not feasible, it's not realistic. But even if it would be, there's a huge opportunity cost because we cannot spend these funds and we cannot have these people working in other parts of our economy. So we do face the same challenges, increasing costs within the healthcare system, a staffing shortage, also in Dutch typically a staffing crisis. We don't have enough people working in healthcare also in the coming years, and therefore a huge pressure on the accessibility of healthcare as well. And there are a number of reasons for this, and you're very much aware of them, I guess. So one, of course, is demographic changes, the aging of the population, but also the increasing focus on prevention, having people live healthier lives, but therefore also longer lives, and in the end of their lives still incurring substantial costs to the healthcare system. And one of the main causes of these increasing costs is seen to be healthcare innovations. Innovations that aim to increase the quality of our healthcare system, but at the same time also increase the costs within our healthcare system. And of course, I will focus on the technology because this is one of the very few causes of these challenges that we can and should actually influence. So to me, what we should do is quite straightforward. We should, first of all, assess the added value, the impact of all the health innovations that are being developed. So we should look at the impact not just on safety or clinical utility, but also on the cost to our healthcare system, the pressure on the healthcare workforce, the use of healthcare resources, and first of all, make sure that we do not have too many innovations entering our system that do not alleviate this pressure, that do not reduce cost or reduce pressure on the healthcare workforce. And of course, in the end, we need regulations and policy decisions balancing aspects related to the cost of the intervention, potential health benefits, and the increasing pressure on our healthcare system. So we need to figure out which balance is acceptable. But for now, it might seem that we need to focus less on the more expensive innovations, unless they have substantial added value, and more on the relatively cheap and cost-saving and workload-reducing type of interventions. And those we should focus on and support their implementation, because in many countries, also in the Netherlands, we see that even valuable digital innovations are not implemented at scale. They're not implemented throughout the entire country. So this is what we should focus on. Maybe you've heard of health technology assessment, maybe not. This is a very recent definition from 2020, stating that HTA, health technology assessment, is really a multidisciplinary process using explicit methods to assess the value of a technology throughout its life cycle. And here the focus is really on making this evaluation process transparent, making it explicit and formal. And health technology here you can understand in the broadest sense. So this is all types of health technology assessment, not just digital health innovations, but also biomarkers, surgical robots, drugs, everything. And this process should be replicable. It should be able to be repeated by different agencies or different researchers with the same results. And here the word value is used, and you can think of value and impact in terms of safety, but also social, ethical, legal consequences of introducing new innovations in healthcare. My expertise is much more related to the quantitative part within this health technology assessment field. So that's really the field of health economics, where we look at the net costs, so all of the cost savings, but also additional costs that are incurred by a new innovation, and the net health benefits, so the health benefits we gain from the technology, but also potential health loss due to complications from a new technology, and also including the staffing component, so the pressure on our healthcare system and the use of healthcare resources. And that's what I will focus on in the remainder of the presentation. And there are basically two ways, at least traditionally, that we can do these health economic analyses. And one is through empirical research, typically some kind of clinical study. And of course, randomized control studies, RCTs, are the most commonly known type of studies because they have the advantage of minimizing the risk of bias in the effectiveness estimate that we're trying to get in these studies. But they also have quite some downsides. So yes, you get very high quality evidence, but they're quite expensive to perform. They take quite a long time to perform, typically a number of years, in order to include participants, follow them, do the analyses, etc. And you need to set up a large study, including those participants as well. In the end, what you get is a nice and a valid estimate of the effectiveness of your intervention, but in a very much controlled setting. So you're really looking at efficacy, the effectiveness under controlled circumstances rather than real-world effectiveness. And most importantly, you only get an answer to a piece of the puzzle. So you only get insight, you can only observe intermediate outcomes rather than final outcomes, because the study will only run for 1, 2, maybe 5 years, but not longer. So any long-term outcomes of your innovations will not be captured in this randomized controlled study. And that's a problem, because within the field of health technology assessment, we should look at all consequences of the innovations, also the long-term consequences, and also unintended consequences. And the alternative that has been gaining popularity, at least in the past decade, is to use simulation modeling to define a mathematical structure that is able to synthesize all the evidence that we have, including evidence from empirical studies, from clinical studies, and use all of that evidence to come up with the best estimate of the impact of our technology. And here, typically, the quality is, well, a challenge, because the quality is determined by, well, how the model is built and how extensively the model input values, the model structure, any assumptions, if necessary, are validated by clinical experts. So we really need to make sure that the models that we use are of sufficient quality and are valid and can be used to support decision-making. But in all of the other aspects, it's relatively easier to perform than a randomized controlled study, because it's cheaper to build this model, it's faster to build these kind of models, it doesn't take as much time and as much resources, and in the end, you can have an estimate of long-term impact of your innovations. So can we apply this to digital health innovations? Well, there are definitely some challenges there. In theory, we can apply a modeling approach and health technology assessment to all types of innovations. But there are some specific challenges, and I will get back to that in a minute, for digital health innovations. And of course, digital health innovations is a very wide concept. You can think of all kinds of different categories of innovations. And I've listed a few on this slide. So one, of course, is providing healthcare at a distance, so remote care, through a digital platform, through the internet, basically interacting, but outside a hospital, for example, interacting with patients at home. But you can also think of technologies that make use of data recorded by sensors or wearables, or from imaging technologies or biomarkers that allow, for example, home monitoring. In the Netherlands, there are many studies ongoing on monitoring patients at home during their recovery from surgery in the hospital. So can we safely discharge patients to home, and can we then monitor them extensively at home, making sure that if something happens, we can get them back to the hospital as soon as possible, but not have them recover in the hospital, which is just more expensive and sometimes also results in a slower recovery, actually, than recovery at home. We can think of apps that support self-management, that provide insight into progression of disease or health conditions to the patient so that he or she can alter their lifestyle or alter their activities based on those information from these wearables and apps. And we can use the information we get from biomarkers and other types of technologies to make sure that we provide the right treatment to the right patient and really personalize our care approach. And I will focus mainly on those innovations that are actually data-driven and that result in actual information provided either to clinicians or patients, helping them coping with their disease or helping them making management decisions. And one of the challenges that we have is that digital innovations can be rapidly developed, and a lot of people are actually doing so. So this is an overview from the end of 2021, where even at that point, there were already more than 350,000 health-related apps in the app stores worldwide. So that's an amazing number, and I didn't count them to check on this, but in any case, it's many more than we can evaluate. And there were more than 250 apps added on a daily basis as well. So this number is only increasing. And one challenge is how to deal with that. Because obviously we can't evaluate all of them, and many countries are now saying, well, if this is really something that is only for, let's say, an individual, if this is a personal decision to purchase by an individual or by a patient, maybe we should not look into this at all. Maybe these are, let's say, low-risk type of innovations. But I have a few illustrations that prove that that's not necessarily the case, and that we might want to look into evaluating some of these technologies in any case. And this is a first example. So this is an example of an app called Instant Blood Pressure that allows you to measure your blood pressure instantaneously. And this is really a quite popular app, but it's also known not to be very accurate. And there was a study investigating how this app works and why perhaps this is one of the most popular apps. And what the researchers did in this study was they enrolled patients, or participants in this case, healthy individuals, into 5 different clinics. They measured their actual blood pressure using the clinically validated instruments, so let's say their true blood pressure. And then they also measured their blood pressure with the app, and they asked them to fill in a user survey, an experience survey. And then they grouped all of those participants into 3 groups. A group for which the app predicted a similar blood pressure as the true one, a group in which the app predicted a higher blood pressure than the true one, and a group in which the app predicted a lower blood pressure. So 3 different groups. And they found quite some surprising results. First of all, the users enjoyed using the app, but also thought it was accurate. Even though there was already scientific evidence that it was not accurate, they thought it was accurate. But more importantly, there also was a negative association between the likelihood of continuing blood pressure monitoring, so keeping on checking your blood pressure, and the result that the app predicted a higher blood pressure than your true blood pressure. In other words, if the app predicted a high or too high blood pressure, people didn't like that. They were not very favorable of that kind of outcome. And the end conclusion was that maybe this underreporting of blood pressure, this inaccuracy in predicted blood pressure actually could be a selling point, or would have been a selling point of this app, because if you predict low blood pressures, people feel well, they like that result, and they keep on using the app. But of course, that can lead to all kinds of complications, right? Because if your blood pressure really is quite a bit higher than you learn from the app, you will not seek any medical care. And you might even end up with complications or cardiovascular events, because your blood pressure is actually much higher than you think it is. And this is, of course, well, a very explicit type of problem where actually incorrect evidence might have been provided to the end users. But it will also affect the healthcare system. And it doesn't necessarily need to be on purpose that you provide incorrect information. I like this example as well. This is from the US, where during one of the skiing seasons, more than 30% of all calls to the emergency services were made by an Apple Watch, because Apple integrated a sensor and an algorithm to detect severe falls and car accidents. And this was actually triggered by people who went skiing and fell down while skiing. And you could think, well, couldn't this have been prevented? Well, there was a 10-second time frame in which the user could actually cancel the call to the emergency service, but that was just too short, and people did not notice, probably even, that the emergency services were called. They were not even aware of this, many people. And one perspective is that you could say, well, better safe than sorry. So yes, there was this call to the emergency service. It wasn't necessary because, well, the individual was just skiing, so no problem. But the problem was that the emergency services were now swamped. They were completely robbed of their resources through these calls. So actual emergencies didn't go through in time because the emergency service 911 was just busy picking up the fake calls from these watches. And of course, it has been fixed now. But even with good intentions, you see that there are consequences, unintended consequences to our healthcare system. And in particular, when you look at data-driven kind of algorithms, tools that help us, for example, diagnose patients or treat patients, these kind of innovations and these kind of algorithms, well, they often fall short of expectations. And a lot have been written about the technologies developed during and after the COVID pandemic. This is just one of those papers listing that a huge number of research groups and companies have developed algorithms to actually detect COVID, for example, on CT scans, or to predict the prognosis of patients who have COVID based on these scans. But in practice, many of those fall short from expectations. And this is just an overview that looked at those models developed in 2020, so the first year of the pandemic. Many more have been developed afterwards. But the general findings are still the same. There are very few actually useful tools that have been developed that are clinically useful, and the vast majority has flaws, methodological flaws, problems with the underlying data or biases, and cannot actually be used in practice. So yes, we have many of these kind of innovations, but most of them do not help us actually improve our healthcare system and keeping it sustainable. And you could say, well, okay, but if we know this, then we should not implement those tools. That's true, but that means we first need to evaluate them to know what their actual impact is. And then we also still need to decide not to implement them. And this is a quite striking example, again, from the US. And this really surprised me, well, quite hugely. Eibich is one of the largest providers of electronic healthcare records systems in the US. So they have data of about 180 million American citizens and their healthcare use. So it's one of the largest companies providing tools for hospitals in the US and also outside. And Eibich has a portfolio of 20, probably by now 30 or more digital health tools, mainly driven by AI, to help clinicians improve patient management, to make the right decisions for the right patients at the right time. And they also have a sepsis prediction model. And sepsis, as you may know, is a very severe complication that can occur in patients that are already hospitalized. And if you detect this too late, chances are quite high the patient will die. So this is a quite important type of tool to detect sepsis in early stages. And they have this Eibich sepsis model with the aim to actually provide a warning for early detection of sepsis. And this was used by over 100 hospitals in the US. So this was used very extensively. And Eibich said, well, the accuracy is around 80% in detecting these kind of cases. But this was a proprietary algorithm, so really a black box type of algorithm, and nobody actually knew how this worked. And because nobody knew, in 2021, researchers performed an independent validation study of this tool, and the results were, well, amazing, but not in a positive way. So using a very large data set, they looked at the actual performance of this tool and found that, well, actually 2/3 of the sepsis cases were missed. So that's more than half. They were not detected by the algorithm, no alert was sent. But also 88%, so basically 8 out of 9 of the generated alerts was false. So in practice, clinicians tended to, if there was an alert, ignore it, because very, very often it was a false alert. So you can imagine that implementing this, and this was used in 100 hospitals, so this affected the clinical management of 10,000s of patients without knowing the actual impact, well, will have resulted in suboptimal treatments, to say the least. And the problem with evaluating these kind of tools and most digital health innovations is also that there isn't a single answer. So you cannot say, well, we've looked at the impact and this is the specific impact of this innovation, for example, of this sepsis prediction model. You can try to do that, but in practice it will always be context specific. So in the Netherlands we see a lot of hospitals, well, assessing digital health innovations for their own context. But we should also look at other types of context and other variables that could influence the impact. And they looked at this in a large study, looking at different algorithms to identify abnormal chest radiographs, where they grouped all patients, all scans basically, into a normal and an abnormal group. So basically saying this is a binary classification task. They looked at different algorithms and they said, well, what's the algorithm with the best performance? And they found one algorithm that had a 72% sensitivity and an 82% specificity, so reasonable performance. But that was not the ultimate goal of this study. Because what they did next, based on this huge data set they had to evaluate this algorithm, was look at the performance in different subgroups. And what you see here is how the use of the algorithm in different subgroups led to actually quite different performance of this best algorithm. And the sensitivity and specificity change depending on the context. So first of all, for example, if you look at age, sensitivity goes up, specificity goes down at higher ages, and the other way around. So sensitivity goes down, specificity goes up at lower ages, which makes sense because at lower ages, typically the disease prevalence is much lower than at higher ages. So this is something you might expect. But the changes are really huge in terms of changes to sensitivity and specificity. And also, it depends on which category of patients you apply the algorithm to, whether these are patients that present at the emergency department or maybe at an inpatient ward or an outpatient clinic or even the ICU. All of this affects the performance of this algorithm. There wasn't much of a difference when it came to gender or region of origin, but even the equipment you use to generate the chest radiograph to feed into the algorithm affects the performance and therefore the value and the impact of the algorithm, as you can see on the right side. So the challenge is there isn't even one estimate of the value and the impact of a digital innovation. Typically, it depends very much on how you use it, when you use it, in who or whom you use it. And there are many of those tools outside that you can use, especially within radiology. There's a website keeping track of all of them, and there are over 200 tools that actually allow radiologists to apply some kind of algorithm, AI or machine learning, to the scans that they produce. And if you just look at CT scans, there are already close to 90 tools that you could implement and that are available. Those are certified in the EU as well. For use in a radiology department. 2 years ago, we looked at studies actually investigating the impact of those tools. So how do these tools benefit us? How do they benefit patients? How do they benefit hospitals or society as a whole? And across 6 years, from 2015 to 2021, we only found 20 studies looking at the expected impact of these tools in clinical practice and in society. So there's a huge effort in developing these kind of tools, but there's very limited effort in actually assessing their added value. And there are a few reasons for that. I think one is that we cannot do these clinical studies, these empirical evaluations for all these kind of digital innovation. There's just too many innovations out there for us to set up a clinical study and assess their value. And also their value depends on the context, so we can't really repeat a clinical study in different contexts over and over again, slightly changing how a tool is actually used. But we can use this simulation modeling approach to include these characteristics. And another key problem is that these kind of innovations are developed at high speeds. So the development process is quite fast, but they're also continuously improved and updated. And we don't yet have frameworks in place, and we're working on this, to align our assessment procedures with this continuous development and improvement process. And finally, since many of these tools are assessed locally or regionally by hospitals or collaborations of hospitals looking at the added value from their own perspective. Much of the data that's used for these analyses, but also the models that are built for these analyses and the results that come out of these analyses are not shared within a region or a country or between hospitals as much as they should, because they're all local or regional initiatives. So how can we link the evolution of these kind of technologies with the evaluation process that we would want to have in place? Well, one way to do that is to link this continuous improvement cycle with a process called living HTA. Basically a dynamic process, a pipeline of the entire assessment process where we say every time new evidence becomes available, we will actually use this within our assessment process. And this pipeline for the assessment would really be searching for new evidence, extracting the evidence if needed from literature or data sets, synthesizing all of these evidence, this could be in some kind of meta-analysis, using a simulation model, which you can develop once and then update over time, update with new evidence, do the actual analysis, look at costs, look at impact on health outcomes, impact on healthcare resource use, etc., and generate a report out of that analysis. And we're not there yet, but for all of these individual steps, there are tools that help you do this in a semi-automated way. So now we're working on connecting these dots, basically, and making this at some point into an almost fully automated process that can be triggered whenever new evidence becomes available. Of course, we still need then to share the study results and make sure that everybody can adapt this analysis based on their own context as well. And finally, if we have those results, we can actually also feed it back into the improvement and development cycle of the digital health innovations. And this is really the philosophy behind early health technology assessment, where you do the analysis not to come up with a definitive answer on the value or the impact of a technology, but you do the assessment to inform further development steps. And I have two examples of that I will just discuss briefly. So this is a study focusing on early osteoarthritis and how to help patients with early osteoarthritis manage their disease. And we are currently building a simulation model that compares usual care, in this case, regular monitoring at a general practitioner, but no treatment at all, because we don't have a treatment for this condition, with a new strategy where we actually develop a tool, an e-health digital tool, to help patients manage their disease. And these are patients with knee osteoarthritis. And this is just a schematic, so this is not a technical description of the model, but what goes in is really how fast the disease progresses, whether it's stable, slowly, or fast progressing, whether the patients have complaints, and if they do, if they go to a general practitioner or a physiotherapist for treatment, any kind of related events such as cardiovascular disease, for which these patients have an increased risk if they move too little, or dementia, and of course also intermediate clinical endpoints like joint replacements. And we know that the earlier you need a joint replacement, the higher the likelihood you need a second or even third joint replacement. And every time you get a joint replacement, again, the results will, in general, on average, will be worse. And we'll follow up those patients and record the patient-reported outcomes, quality of life, burden of disease, but also their healthcare use and the medical staff required to actually help and support these patients and their own productivity as well. And what we are developing is a digital health innovation that first of all helps predict progression of disease, whether this is fast, slow, or maybe stable, and generate optimal movement advice. And that's something we don't have now, because you can move too much, but you can also move too little, and both of those are suboptimal for your health. So we will generate a personalized movement advice for these patients, but we're still working on this tool. So the actual advice is likely to be suboptimal, at least when we start, and then we continue the development process. We will measure whether or not patients actually adhere to this advice, because it's just an advice. So they might not adhere at all, or just maybe for 3 weeks, or maybe over a longer time period. And in the end, that will determine also how fast that disease is progressing. And here, of course, the aim is to have more patients with stable disease or slowly progressing disease and less patients with a fast progressing disease. But the fun part is really that we can follow up these patients as well in the model and compare and look at the impact of our innovation, right? The impact on healthcare resource use or productivity or all of the other outcomes. But this is not a fixed endpoint. This is not a, let's say, a one-time analysis. So what we're going to do is, first of all, we're going to monitor these patients, have them put in their experiences and complaints, and also use this to further optimize their personal movement advice. So if a patient gets told he or she needs to move more, and they actually do, and as a result of that they develop more complaints, we will feed it back into the algorithm to optimize the digital health innovation. But we're also going to use every update cycle of this digital health innovation to again redo the health technology assessment. So if we know that the movement advice has a higher chance of being optimal, if we know that with a new interface, for example, patients are more likely to adhere to the movement advice, we will repeat the health technology assessment again using the same model but different values for the inputs, and again look at the added value of the complete intervention. As a final example, and this is something in a different field, I have an example on the FAST MRI study we are looking into, and FAST MRI is, I think, an overall name for a lot of different projects, all aiming to reduce the scanning time of making an MRI scan by a factor 2 to 8. And a lot of consortia are working on this, and Maître, the parent company of Facebook, is supporting some of those consortia that focus on using AI to actually be able to do these scans much, much quicker. And they focus, of course, on the performance of reconstructing MRI images based on short scan times. And they're doing a very good job. You see 2 images here, and they're nearly indistinguishable, I think. The top one is a traditional MRI, and the bottom one is one that was developed using 4 times less scan time, so 4 times quicker, and then reconstructed using AI. What we're doing now in the Netherlands is looking at the value of this technology, and you can think, well, if you can do the scans more quickly, surely that has a lot of added value, right? That's what you would think. That's also what I think. But it is very hard to actually quantify the benefits of that. So we're discussing this with a lot of different hospitals interested in this technology or experimenting with this technology. And first of all, we don't know yet how this freed up capacity is used. So if we can do more MRIs, how does that benefit us? How does that benefit patients or the hospital or society? And if we don't have a strategy, that was the CEOs of the hospitals are telling me, if we don't have a strategy in place to make use of these resources, they will just disappear. People will spend more time either with patients or reducing their workload, but we will not be able to quantify this. And if I ask them, well, what is your explicit strategy? How are you going to use this? Then they don't have a clear answer yet. They could use it for more frequent monitoring, for example, in patients with prostate cancer. They could use it to reduce waiting lists, if there are waiting lists for patients getting an MRI. Or they could, and this is also what Maître tells us, use MRI in new patient groups. But the question is whether that's valuable and which patient groups we should then focus on. An important other question is, well, can we actually make use of those MRI machines more often? Because in the end, we still need a radiologist to interpret the images, right? So if we can do 4 times as much MRIs, that doesn't mean we have 4 times as much radiologists to actually interpret the results of the MRIs. So at least in the Netherlands, there's probably a bottleneck that's coming up quite quickly that yes, we can do more MRIs, but we cannot interpret more MRIs because we don't have the radiologists for that. So we need to account for that as well. And finally, and you see this with many digital health innovations, if we can do the MRI faster and therefore it should be cheaper, health insurance companies are likely to also provide lower reimbursement rates for these MRIs to hospitals. So unless the hospital can really make a business case and use the freed up capacity to create value, there's no incentive for the hospital to start using this technology, because they will just get lower reimbursement, but they still have the same equipment, the same radiologists, and they also need to purchase a license for this algorithm. So there are a lot of challenges here to actually look into the benefits that this technology would provide. So to wrap this up, in conclusion, I think we need digital health innovations. We need them to address the challenges I started out with. We really need them. And I've given you some examples of, let's say, innovations that didn't work out that well. But it's only because I believe that we also still need to assess the value of those digital health innovations, and we need to focus on the ones that help us keep our system sustainable. And we need to leave out the others. And we need simulation modeling to look at these technologies and assess their value. It's just not feasible to do empirical studies for all of them. And also, we do want to know their value in different contexts and look at their optimal use. And this is something we can do with simulation modeling, and it's also something we can do to align with the continuous development process. So to speed up our assessments, so to say. And of course, it still means we need tailored approaches. Some of those innovations will be high risk, some will be low risk. We need to classify them. But in the end, I think we can do this. And if we use simulation models that are also open and transparent, that will also make our assessment procedure as a whole more efficient. And this is something we need to work on to make sure that we share the results of these analyses, share the data, share the simulation models, and also share the results in order to learn from each other and make the assessment procedures more efficient and also therefore feasible for these types of digital health innovations. Thank you.
Thank you very much, Erik. We have some time for questions. If you would like to ask a question, most should have a microphone in front of you. It would be great if you could use that. There's a little button on the right that you need to turn that on. If for those sitting in the back rows, you can also raise your hand and I can bring the speaker microphone to you. Pierre.
Thank you, Peter. Many thanks for your talk. At the beginning, you were talking about HTA, Health Technology Assessment, which is usually mainly driven by pricing and reimbursement decisions at the country level or for any jurisdiction. And we know in Europe that Germany was leading the adaptation of HTA for digital technologies with DIGA, if I'm correct. What's the case in the Netherlands? Because we know, and Madame Collignon probably will talk later about the French case, but what's going on for your country?
I think in this respect, Germany is ahead of us. So we're experimenting in the Netherlands with at least a few digital technologies and experimenting in the sense that they are implemented, get reimbursed, and we will evaluate them after 1 to 2 years. But this is really a small selection. So what we also see is that for many tools focusing on remote care, but also the tools that you use in hospitals, they're really collaboration between hospitals, groups of hospitals that themselves start evaluating those tools. And that's not on a national level, that's really on a regional level. So I think we should move towards having more tools enter this procedure of conditional reimbursement, implementation, and reassessment after, for example, 1 or 2 years. Yeah.
That would have been my question. So a link to the reassessment. How to? I think it's a question that could be for both of you after maybe your speech and your keynote. But how to assess and how to support tech players within the evaluation after the first evaluation. As you know, the technological tools are evaluated quite fast. and we are adding new features. And so how to support, maybe with more agile framework, the re-evaluation of these solutions.
Thank you. I think that's a good question, and I think that's one of the questions where part of the answer would lie in a more frequent use of simulation models to assess those technologies, because they can be adapted quite easily. In particular, when new evidence becomes available, if you think about diagnostic tools, if they become more accurate, you can just immediately redo the analysis. If you add something, let's say, to the user interface, which would make it easier to use but not necessarily more accurate or so, then it's harder to take into account. So I think in the end we also need to create different, let's say, classes or categories of improvements and decide when we want to re-evaluate, when we think this is valuable or even necessary. And of course, for diagnostic technologies, if you actually change the algorithm, you should get a new certification as well. If you change the user interface, it might be a minor improvement and you don't necessarily want to re-evaluate and change the reimbursement, for example. That's what I would propose.
Hi, thank you very much for the talk. So, yeah. I have a question on, well, the evaluation of, let's say, the EPSIS model. So typically a decision aid tool that is making a prediction on how at risk is a patient. So is the evaluation just about saying how well, basically evaluating the performance of the model, the performance of the algorithm, and saying how well the true outcome aligns with your model prediction in a new sample? Or is it a bit more complicated than that, in the sense that when you actually implement the model, in clinical practice, then behaviors can change around it? So typically the physician can react to the implementation of the algorithm by changing his clinical practice, and so the data generating process is changing itself. And then you also have other problems, right? So the model is predicting one specific outcome, so in that case, whether or not you're at risk of sepsis. But if other outcomes actually matter for you or the policymaker or health policy, so typically, whether it's a serious, the severity of the risk, or then evaluation could be even more complicated, right? So if your model does better at predicting risk, but not better at predicting serious risk, or if exacerbate age or race or gender disparities in the pool of people at risk, so what is your point of view on these questions?
Thank you. That's a good question. I don't think we can take all of that into account. Of course, we try to. In the end, of course, these kind of algorithms, everything should start with safety. And then next up, you have diagnostic or statistical performance. However, we also know that this statistical performance doesn't necessarily connect to or results in improvements in terms of health outcomes or cost savings or etc. So I think that's something we should look at, because those outcomes are of interest to all of us, to society as a whole. And you're completely right that sometimes if you implement a tool, it actually influences behavior of the patients or clinicians or other care providers that use the tool, or even do not use the tool but are aware of the tool. And this is something that in general we don't really account for, because we don't know how the behavior changes. But it is something to consider and to say, well, if this is a change we expect, and if the change in behavior that we expect would really be relevant, then it should be included in the analysis. But then you also need to measure these kind of changes. Do they actually occur? And a very simple example of this kind of change that we do incorporate quite often is learning behavior as well. So being able to learn to use a new technology. And of course, if you first use it, then you'll likely make mistakes. But we also know that with training and experience, that chance decreases over time. And in the end, we want to have a best estimate of what the digital tool would add, what the value it would have if it would used in a setting where people are used to it and know how to use it. But there's a lot of context around it that typically we don't include. Theoretically we could, but it's also balancing the amount of time and effort you put in the assessment and what value all of those components would add to the assessment. Would it change our result? Would it change our decision, for example?
Okay, thank you very much for this insightful presentation. And now allow me to ask you about the different, like we're talking a lot about generative artificial intelligence, so how you see the opportunity of generative AI in digital health innovation, and mainly like, what we can do like in terms of responsible artificial intelligence algorithm and the regulatory behind all the ethics and etc. Thank you.
That's a good question, but I'm not an ethicist. That's not really my area of expertise. What I do think we should do more, much more, is actually keeping track of the consequences and the outcomes that relate to the innovations that we do implement. So if we have an AI algorithm that is demonstrated to be safe, it could still work suboptimal. It could still actually increase health inequalities, inequity, where we expect it to decrease those inequalities. So what we should do more often is actually keeping track of the outcomes of those tools that we do implement to be able to reassess them, whether this is on health outcomes or cost or health inequalities in the future. And we can't do all of that upfront, I'm afraid, but it's something that definitely deserves more attention.
Thank you. I think this is probably a good time to move on, but if there are further questions to Erik, we'll of course have the roundtable discussions, and Erik is going to join us for this, and so there will be more opportunities to discuss this very stimulating keynote. So with this, I would like to introduce our second keynote speaker, Corinne Collignon, from the Haute Autorité de Santé. Corinne is a pharmacist by training, but has very extensive experience in health technology assessment, in particular for medical devices and digital health technologies. She's been deputy head for the assessment of medical devices at HAS for a number of years, and now leads the digital mission of the HAS, and so I think it's going to be great to hear about the work that's been done here in France to try and promote and integrate digital health technologies. Corinne, you can use the clicker, this should work, and here's your presentation.
Thank you, Peter, and good morning to all of you. My speech will be in French, so I think there is a good translation of my speech. Much more easier to talk about technical question in my own language. So Peter explained to you. Sorry. Some trouble to speak to talk in French now. Je suis donc la responsable de la nouvelle mission, enfin nouvelle depuis 2 ans, mission numérique en santé à la HAS, qui a été créée dans l'objectif de donner une impulsion, en tout cas de questionner, de développer les questions spécifiques autour de l'introduction des technologies numériques en France et dans tous les sujets que la Haute Autorité de Santé a traités. Donc c'est vrai que j'ai passé plusieurs années au service d'évaluation des dispositifs médicaux et c'est pour ça que j'ai une bonne expérience de l'évaluation de ce type de produits de santé. Mais effectivement, il y a des questions spécifiques qui concernent les dispositifs médicaux numériques, et notamment dans le fait qu'on n'évalue pas tout en France, et ça va être le fil conducteur de ma présentation, de montrer ce qu'on n'évalue pas, et pour ce qu'on n'évalue pas, ce qu'on est en train de mettre en place pour éclairer les choix. Erik, juste avant, a donné une bonne illustration de l'hétérogénéité des technologies, de leurs performances et des enjeux. Et effectivement, sur les technologies numériques, on va les retrouver sur l'ensemble du parcours de soins et même au-delà du soin, désormais dans nos vies quotidiennes avec tous ces objets connectés. Il y a évidemment énormément d'enjeux technologiques et d'enjeux cliniques autour des stratégies de prévention dans l'utilisation de ces technologies de santé. Donc on le voit, ces technologies sont partout et un bon nombre d'entre elles ont des finalités médicales. Alors elles se caractérisent par une très grande hétérogénéité, et cette slide l'illustre volontairement, tant d'un point de vue de leur nature technologique, donc certaines sont des applications, d'autres sont des plateformes, d'autres sont finalement des briques logicielles intégrées à des dispositifs de type hardware. Et du coup, ces technologies vont, pour certaines d'entre elles, être basées sur des algorithmes qui ne sont pas forcément ce qu'on qualifie d'intelligence artificielle, et puis d'autres intègrent des technologies d'intelligence artificielle. Alors les enjeux et les apports sont évidemment essentiels. Il y a une manne technologique absolument fantastique, et dans cette effervescence technologique, l'enjeu il va être de définir ce que ces technologies apportent et où sont les pépites. Il y a des vrais leviers pour renforcer les stratégies de prévention, pour personnaliser les soins et transformer les parcours de soins, et ces technologies représentent un vrai levier de transformation des parcours de soins en France. Évidemment d'optimisation des ressources médicales pour les mettre au bon endroit. Alors je suis désolée, le pied de page de médiapositive est énorme, mais ce n'était pas volontaire. Il y a eu une petite transformation en cours de route, mais je m'en aperçois maintenant. Donc véritable optimisation, enfin levier d'optimisation des ressources médicales pour mettre à leur juste place les soins médicaux, et éviter par exemple les pertes de temps sur des tâches administratives que connaissent actuellement les soignants, et on sait qu'on doit préserver leur temps par les temps qui courent, et également améliorer l'efficience de notre système de santé de manière générale. Alors, je ne peux pas faire cette présentation sur le numérique sans parler de la donnée, parce qu'autour de ces technologies, en fait, c'est le vrai catalyseur technologique et le vrai levier d'amélioration de la performance de ces technologies. Alors, les technologies à base d'IA vont évidemment explorer et utiliser des données extrêmement hétérogènes, à la fois des textes, des images, des vidéos, du son maintenant. C'est le point de départ de tout algorithme apprenant. Les technologies peuvent se développer parce que maintenant on est capable de traiter un volume de données massives avec ces nouvelles technologies. Et l'enjeu, il est véritablement sur la qualité des données à partir desquelles les technologies de santé sont désormais développées. Donc on a un besoin d'avoir des données parfaitement propres et bien annotées. Le plus souvent, elles sont utilisées à des fins non pas primaires mais secondaires, donc pas pour soigner les patients, mais le plus souvent maintenant elles sont réutilisées. Donc il y a évidemment des enjeux juridiques autour de ça, mais c'est pas le sujet de mon intervention. Et puis c'est un vrai levier pour développer l'agilité pour les entreprises qui développent des technologies de santé, pas seulement des dispositifs médicaux numériques, mais aussi des médicaments. Donc on voit apparaître avec ces technologies d'intelligence artificielle des développements plus rapides, plus agiles, grâce à cette émergence de données de santé. Alors, nos missions, en fait, s'articulent autour de trois piliers. Il y a un axe de nos missions qui consiste à évaluer les technologies de santé, et donc notamment un certain nombre d'entre elles sont des technologies numériques. L'autre axe de nos travaux, c'est d'émettre des recommandations de bonnes pratiques professionnelles et également de mesurer et d'améliorer la qualité des soins en France. quand on va parler numérique, en fait, en général, on touche à ces 3 piliers. Et l'objectif du service que je dirige, c'est d'essayer de donner l'impulsion sur ces 3 axes. Je vais commencer par le premier axe, en fait, puisque c'est le point de départ, l'introduction de ces technologies dans les soins en France. La mission de la HAS, quand on parle d'évaluation de technologies de santé, c'est d'éclairer le décideur public. Donc en général, nos évaluations sur l'axe évaluation technologique, c'est d'éclairer les décisions de remboursement et également de négociation de prix, de fixation de prix en France. Donc dans ce cadre-là, on n'évalue pas toutes les technologies, il faut que ça rentre dans les silos de remboursement. Alors les silos, ils sont assez nets, même si on peut toujours discuter des produits un peu frontières entre ces silos. Tout ce qui n'est pas à finalité médicale déclarée, donc par l'entreprise, donc tout ce qui n'est pas dispositif médical, ne fait pas l'objet d'évaluation par la Haute Autorité de Santé en France. Notre périmètre de remboursement, il est au milieu de cette diapositive. C'est plutôt les dispositifs médicaux qui sont utilisés par le patient directement, donc à des fins thérapeutiques notamment, ou récemment également ceux qui mettent en relation le patient et une équipe de soins à des fins, dans le cadre d'une télésurveillance médicale. L'initiative de cette évaluation, elle est toujours à la main de l'industriel. Donc la HAS ne s'auto-saisit pas en général pour évaluer une nouvelle technologie. C'est le plus souvent une initiative de l'industriel et quand il veut un remboursement individualisé par l'assurance maladie. Il y a un autre volet des évaluations à la HAS qui sont les évaluations d'actes professionnels. Évidemment, la HAS évalue des actes professionnels, mais il ne s'agit pas d'une évaluation d'une technologie de santé. C'est quand, pour qu'un professionnel réalise un nouvel acte, son geste puisse être tarifé. Donc, quand il n'y a pas d'acte associé à une technologie nouvelle qui existe ou quand il faut adapter un acte existant. Mais il n'y aura pas d'évaluation dans ce cadre-là, de technologie par technologie, c'est bien l'évaluation de l'acte pour la rémunération in fine du professionnel. Ce qui veut dire qu'en 2023, à ce jour, la plupart des technologies avec intelligence artificielle n'entrent pas dans les cadres d'évaluation de la HAS. Donc il n'y a pas d'évaluation sur le plan national. Alors il y a une évaluation pour la mise sur le marché, évidemment il y a le marque HCE, mais il n'y a pas d'évaluation de l'intérêt clinique dans le sens HTA pour ces technologies-là, la plupart du temps. Alors, on évalue quand même quelques petites choses, et donc la partie du milieu de ma diapositive précédente, il y a un cadre spécifique quand même pour les dispositifs médicaux numériques utilisés par le patient ou ce télésurveillance qui vient d'être mis en place. Donc, c'est issu de la loi de finances de la sécurité sociale pour 2022. Les textes d'application ont rendu possible la mise en place du processus cette année. Donc, ça y est, le guichet numérique est lancé. Donc, il y a donc désormais un cadre de droit commun pour la télésurveillance médicale et également un cadre dérogatoire, donc un fast track qui s'appelle la prise en charge anticipée avec un acronyme PECAN pour à la fois les technologies de télésurveillance médicale et les technologies numériques à visée thérapeutique. Dans ce nouveau processus dédié aux technologies numériques qui a été mis en place, c'est la même commission que celle qui évalue les dispositifs médicaux que je vais appeler classiques, qui est la CNEDIMS. C'est une commission, la HAS, qui est spécialisée dans l'évaluation des dispositifs médicaux, donc numériques ou non. Dans le processus qui a été mis en place cette année, on voit d'emblée des spécificités par rapport au processus existant. Donc c'est certes la même commission qui va les évaluer, mais elle va suivre des critères spécifiques. Pour la télésurveillance médicale, ça va être un binôme dispositif médical numérique et organisation de soins associés qui va être évalué de façon indissociable. Et on voit là la particularité des dispositifs médicaux numériques, c'est que sans l'utilisateur, en fait, il n'y a pas de plus-value médicale. Donc c'est bien un dispositif médical numérique et ce que l'utilisateur en fait. Et donc l'enjeu sur l'organisation des soins associés est d'emblée mis en lumière par le processus français mis en place. Également un modèle économique très spécifique puisque ce sont des forfaits qui ont été fixés pour ce type de technologie. Et donc des forfaits que je vais appeler génériques. Il n'y aura pas de négociation produit par produit avec le décideur public à l'issue de l'évaluation par la HAS. et donc des critères spécifiques d'évaluation qui résultent de ces particularités. Alors notre rôle, le rôle de l'HAS, c'est d'évaluer donc ces technologies, que ce soit dans le cadre d'une prise en charge anticipée ou dans le cadre du droit commun de prise en charge de télésurveillance médicale, quand les industriels veulent une inscription sous nom de marque. Donc c'est la CNEDIMS, la commission spécialisée de la HAS, qui va évaluer, qui rend un avis au ministre consultatif, et la décision appartient toujours, là, on reçoit un appel au ministre. La décision appartient toujours au ministre qui formalise sa décision par un arrêté d'inscription. Alors en pratique, l'industriel, je vous l'ai dit, est à l'initiative de cette demande et peut choisir en fonction de l'avancement de son plan de développement et de la preuve dont il dispose une démarche en 1 ou 2 temps. S'il a toutes les données et les résultats, par exemple, d'une étude pivot, il peut venir directement prise en charge de droit commun et il sera évalué dans ce cadre-là pour une durée d'inscription au maximum de 5 ans qui nécessitera, et je reboucle avec la question qui a été formulée tout à l'heure, donc il y aura forcément, pour les technologies qui sont inscrites au remboursement de façon individualisée, une réévaluation à horizon maximum de 5 ans. Et puis également, il peut choisir de passer par la case de la prise en charge dérogatoire parce qu'il n'a pas encore toutes les données disponibles et donc bénéficier de ce fast track, cette prise en charge anticipée avant de venir en droit commun. Alors cette prise en charge anticipée, sa particularité, elle ressemble aux voies de remboursement et la prise en charge qui existe pour les autres dispositifs médicaux classiques. C'est une prise en charge transitoire qui a vocation à donner une réponse extrêmement rapide à l'entreprise qui en fait la demande, mais il faut savoir qu'elle est seulement pour 1 an et qu'elle n'est pas renouvelable. Elle est valable uniquement pour les dispositifs médicaux numériques de 2 types, ceux à visée de télésurveillance médicale et également ceux à visée thérapeutique, donc une application utilisée par le patient tout seul chez lui, sur prescription médicale, puisque le point de départ, c'est une prescription médicale, mais c'est bien le patient qui va utiliser l'application à des fins de réhabilitation, rééducation, autotraitement, etc. Ce qui va se passer, je qualifie cette prise en charge anticipée d'antichambre du remboursement, c'est qu'obligatoirement, à horizon de quelques mois, donc 6 mois pour un dispositif médical à visée thérapeutique ou 9 mois pour une télésurveillance médicale, l'industriel a l'obligation, il doit s'engager à ça, de déposer un dossier de prise en charge classique. Donc ça veut dire que cette prise en charge anticipée, elle sert aux industriels à terminer en fait la collecte des données pivotales qui vont permettre de démontrer l'intérêt de leur technologie avant la prise en charge classique. C'est un vrai levier, quelques mois ça peut être tout à fait salvateur et précieux, mais il faut se préparer dans la démarche à la prise en charge classique très très rapidement. C'est pas une fin en soi, c'est ce que je veux dire. Les critères d'éligibilité ont été définis par les textes, c'est-à-dire qu'ils sont imposés à la CNEDIMS, elle n'a pas le choix, donc elle va s'approprier, elle est en train de s'approprier sur les premiers dossiers les nouveaux critères d'éligibilité formulés pour la prise en charge anticipée des dispositifs médicaux numériques. Le prérequis, c'est le marquage CE. Ça, c'est valable pour tout dispositif médical dans le cadre de nos évaluations. Et la commission va statuer sur la présomption d'innovation. Cette présomption d'innovation, et c'est important, elle peut être sur l'angle du bénéfice clinique ou du progrès dans l'organisation des soins. Et la commission va juger, et les textes sont très précis là-dessus, sur les premières données disponibles et en prenant en compte les éventuels comparateurs pertinents. Alors, des précisions ont été apportées par rapport à la loi dans un décret de cette année. Le progrès dans l'organisation des soins ne doit pas altérer la qualité des soins. Donc ça veut dire que le bénéfice organisationnel ne doit pas se faire au détriment de la qualité du suivi clinique apporté aux patients. Et la commission doit prendre en compte le fait, dans l'appréciation de la présomption d'innovation, le fait que les études qui sont en cours et que l'industriel apportera à horizon de 6 à 9 mois sont de nature à apporter les données suffisantes dans les délais impartis, donc très courts, 6 à 9 mois, pour une évaluation de droit commun. Donc là, vous avez sur cette planche la timeline en fait, de l'évaluation, et vous voyez que la commission a 60 jours pour rendre son avis, à partir du moment où le ministère a acté de la recevabilité administrative du dossier. Et que le ministre a, lui, suivant cet avis, 30 jours pour prendre sa décision. Et puis la suite logique, c'est dépôt de dossier droit commun, je le répète, 6 à 9 mois, selon le type de technologie. La différence de durée, là, entre 6 et 9 mois, elle s'explique par le fait que pour la télésurveillance médicale, il n'y aura pas de négociation du tarif de remboursement et du prix limite de vente avec le comité économique des produits de santé. Donc comme les forfaits sont très fixés, on n'a pas cette étape après l'évaluation de la CNIMS de négociation tarifaire. En revanche, pour les dispositifs médicaux à visée thérapeutique, dont le point de chute final, c'est une inscription sur la liste des produits et prestations remboursables, donc la liste classique pour les autres dispositifs médicaux qui existent. Après l'évaluation par la CNIMS, il y a une négociation du prix et du tarif de remboursement avec le comité économique des produits de santé au ministère, ce qui fait qu'il faut un peu plus de temps pour rejoindre le droit commun. Et la logique aussi de ces contraintes réglementaires, c'est qu'il n'y ait pas d'interruption entre une prise en charge anticipée et le point de chute qui est le droit commun. Donc il y a un continuum de prise en charge, d'où ces enjeux calendaires imposés par les textes pour ces technologies numériques. Alors quelques mots sur cette nouvelle liste des activités de télésurveillance médicale, donc la liste dédiée pour la prise en charge des dispositifs médicaux qui servent à la télésurveillance médicale et également de l'activité de soins associée, du forfait opérateur. La particularité pour l'inscription sur cette liste, et c'est lié aux modalités de tarification, c'est qu'il y a un seul critère sur lequel la CNIMS va rendre son avis, c'est l'intérêt attendu. En revanche, elle va le caractériser selon 3 composantes. Soit l'amélioration clinique de l'état de santé du patient, soit le gain significatif dans l'organisation des soins, soit sur l'intérêt de santé publique. Et ce que prévoient les textes, c'est que dès lors que l'intérêt attendu est positif sur une de ces 3 composantes, le produit peut être inscrit. Donc ça peut être une amélioration clinique de l'état de santé ou un progrès dans l'organisation des soins, ou les deux. À titre personnel, j'ai du mal à voir comment on pourrait avoir seulement un intérêt de santé publique. Je pense que ce sera forcément lié à un des 2 critères, mais on verra si à l'avenir on a des technologies qui ne présentent qu'un intérêt de santé publique, mais je n'ai pas d'exemple en tête. Voilà, donc on peut avoir l'un ou l'autre, amélioration clinique ou gain significatif, ou les deux, et ça suffit pour démontrer l'intérêt attendu. Et je vous ai mis sur cette planche un exemple du coup d'arrêté tarifaire. On n'a pas tous les arrêtés, mais celui sur la télésurveillance montre qu'il y a une gradation selon les composantes sur lesquelles on a un impact. Pour la télésurveillance médicale, donc la qualité de vie est un peu mieux remboursée que l'impact organisationnel. Après, dans la gradation des remboursements, on a la morbidité et enfin l'impact sur la mortalité. Donc vous voyez que ces tarifs sont préfixés, qu'il n'y a aucune négociation. À l'issue de l'évaluation CNIMS, c'est une inscription directement. Donc avec ses avantages et ses inconvénients, c'est que ça va vite, mais qu'il n'y a pas de négociation produit par produit. Donc la timeline, oh là, il y a eu un saut de mise en page assurément sur mes slides, mais c'est pas grave, ça reste lisible. La timeline de cette inscription sur la liste des activités de télésurveillance médicale, elle est un peu différente de celle pour la prise en charge anticipée. Dans les prérequis, il y a le certificat d'interopérabilité et de sécurité qui est établi par l'ANS, donc au même titre que le marquage CE, ça fait partie des éléments qui doivent être déposés, en tout cas acquis au moment où l'industriel dépose son dossier. Il dépose son dossier, ça c'est un point très particulier également au Conseil national professionnel, et c'est lié au fait que l'activité de télésurveillance médicale, elle va, en tout cas la prise en charge, elle va combiner celle du dispositif médical et celle de l'activité du professionnel, et donc le législateur a prévu que le dossier soit déposé aussi auprès des conseils nationaux professionnels concernés. Il y a une instruction par la CNIMS qui doit rendre son avis phase contradictoire comprise dans un délai de 90 jours. Et cet avis, à l'issue de la phase contradictoire, il est dit définitif. Il est adressé aux ministres, à l'industriel et également aux conseils nationaux professionnels concernés pour une décision ensuite ministre. Alors après cette séquence qui vous explique les processus spécifiques mis en place pour l'évaluation des dispositifs médicaux numériques, et vous voyez que ça concerne des thématiques très particulières, thérapie numérique et télésciences médicales, je propose d'enchaîner sur les enjeux spécifiques que nous avons identifiés au fil des années autour de cette technologie numérique. Ça a été dit dans la présentation précédente, mais il y a une très forte évolution technologique, et ça a des conséquences sur le plan de développement clinique et sur la transposition des résultats des études cliniques aux versions ultérieures. Donc ça, c'est des éléments qui doivent être anticipés, que la Commission doit aussi gérer dans les données qui lui sont soumises. Et c'est une très grande particularité des dispositifs médicaux numériques. J'ai travaillé pendant des années sur les dispositifs médicaux classiques, c'était déjà un sujet, mais c'est vraiment accentué sur le volet numérique où tout va beaucoup plus vite en termes d'évolutivité. L'autre particularité, c'est que ces technologies, elles ont vocation à interagir avec d'autres outils, dispositifs médicaux ou pas, enfin d'autres technologies numériques. Et du coup, ça pose la question dans un plan de développement clinique du champ de l'évaluation de la technologie. Est-ce qu'on évalue uniquement une brique logicielle ou une application et l'organisation des soins qui va avec? Donc la dimension de l'évaluation, elle doit aussi être calibrée dans le plan de développement de l'industriel. Et puis évidemment, il y a le sujet particulier de l'intelligence artificielle avec une nécessité d'adapter les cadres d'évaluation. Et pour l'instant, il y en a pas beaucoup. Donc on a mis quelques petits éléments en place. Et également la question de l'impact organisationnel, parce que pour la plupart de ces technologies, l'enjeu va dépasser le volet clinique, mais va être plutôt sur le plan des organisations de soins. Alors, ce qu'on a mis en place au fil des ans, et vous voyez qu'on a commencé à se préoccuper de ces questions numériques il y a maintenant plus de 6 ans. On a commencé par être... Enfin, voilà, c'est une démarche pas à pas. On a commencé par faire un guide de dépôt spécifique pour les dispositifs médicaux numériques pour permettre aux entreprises qui nous déposent des dossiers de nous apporter les éléments particuliers qui nous sont nécessaires pour comprendre la technologie. On a enchaîné sur des questionnements plutôt méthodologiques d'évaluation des dispositifs médicaux connectés. À l'époque, on utilisait ce terme-là. Je pense que si on refaisait ce guide, on l'appellerait différemment et on parlerait de numérique. Un élément qui me semble phare et qui reboucle avec les questionnements sur le besoin d'un cadre, c'est les travaux que nous avons produits sur une grille d'évaluation pour l'intelligence artificielle dans les dispositifs médicaux. Et du coup, ça, c'est pour nous un travail qui a permis de donner de la confiance aux membres pour se préparer à l'évaluation de technologies, embarquant l'intelligence artificielle dans les dossiers qui nous étaient soumis. On a enchaîné sur une classification des solutions numériques sur la finalité d'usage pour développer des approches de type matriciel sur ce qu'on doit évaluer notamment. Des travaux spécifiques sur l'impact organisationnel, une expérimentation qui a été lancée depuis quelques mois sur l'évaluation médico-économique spécifiquement pour les dispositifs médicaux numériques à la HAS, et puis une réflexion sur les dispositifs médicaux à usage professionnel. En 2023, le guichet numérique a été lancé. Donc globalement, c'est un process assez continu d'adaptation des méthodes, des périmètres d'évaluation, et je pense que ce n'est qu'un début. Donc on a beaucoup de choses à mettre en place pour construire ce cadre de confiance autour de l'évaluation de ces dispositifs médicaux numériques. Et donc la première brique, à l'époque où on parlait de dispositifs médicaux connectés à la HAS, a permis de soulever la très forte rapidité d'évolution technologique qui devait être prise en compte dans nos évaluations, et le fait qu'il fallait guider les entreprises dans leur programme de développement clinique pour savoir ce qui était acceptable en termes d'extrapolation de données, et du coup un raisonnement en fonction de la fonctionnalité principale et des évolutions qualifiées de mineures ou majeures qui permettent à la Commission et donner de la transparence aussi pour les industriels sur ce qui peut être accepté par la Commission. Le périmètre d'évaluation, je vous le disais, avec l'interaction de ces produits avec d'autres dispositifs, le fait qu'ils sont dans un écosystème et qu'il faut se poser très tôt la question de qu'est-ce qu'on veut isoler comme effet? Est-ce que c'est l'effet du produit ou l'effet du produit d'une organisation? Ça, c'est un point, à mon avis, clé pour la construction de plans de développement. Et puis, le troisième volet de spécificité, c'est l'existence de systèmes experts qui traitent de l'information, donc la notion d'intelligence artificielle, avec un besoin de transparence sur ce qui est soumis pour l'évaluation. Pour la CNEDIMS, en fait, l'objectif a été dès le début de ne pas vouloir changer son rôle, en fait, mais de comprendre ce qui lui est soumis et de générer de la confiance. Donc c'est vraiment le cadre de confiance qu'on a essayé de mettre en place assez rapidement, d'abord pour les membres, mais aussi pour produire des outils pour les professionnels, afin qu'ils puissent savoir ce qui leur est soumis quand un industriel leur propose une technologie. Donc voilà, lever un peu l'effet boîte noire sans rentrer dans le détail du modèle mathématique, mais comprendre comment fonctionne le modèle. Donc c'est ce que j'illustre sur cette slide. La CNEDIMS a jugé très tôt qu'elle n'avait pas besoin de connaître l'amont, la qualité des données, la création du modèle décisionnel. Qu'elle n'avait pas besoin de connaître le modèle mathématique, mais elle avait besoin d'avoir des éléments sur les données qui ont servi à la construction du modèle et aussi sur l'aval. Et du coup, c'est un outil qu'on a construit après consultation publique parce qu'il n'y avait pas du tout d'outils de ce type. Nous avons construit ce qu'on a appelé une grille descriptive des dispositifs médicaux avec intelligence artificielle qui part de la finalité d'usage, et c'est un point d'importance qu'Erik a souligné tout à l'heure, c'est-à-dire qu'on part d'un usage revendiqué, on questionne sur les données d'entrée, les données de sortie. Il y a un certain nombre de questionnements sur le modèle, sur l'entraînement, ce qui a servi à qualifier la fiabilité du modèle, et aussi les caractéristiques fonctionnelles, sa performance, sa robustesse, sa résilience, l'explicabilité. Globalement, ce qui est mis en place par l'entreprise pour suivre sa performance initiale et sa performance dans le temps. Donc globalement, ces 42 items de cette grille constituent un canevas des points clés qui nous permettent de comprendre ce qui est soumis pour l'évaluation. Donc c'est une information descriptive qui est attendue. Il n'y a pas de bonne ni mauvaise réponse, c'est simplement une question de transparence. Et en aucun cas, cette grille ne se substitue aux évaluations de données cliniques, mais ça permet juste de comprendre ce qu'est la technologie et comment elle a été construite. Elle a été construite parce qu'il n'y avait rien. Il y a quelques années maintenant, du coup, pour les besoins des membres de la commission, mais elle est évidemment disponible pour d'autres. Et adaptée à d'autres technologies que celles qui font l'objet de potentiellement nos évaluations. Donc, cette grille, elle permet de questionner sur un certain nombre de points clés pour toute technologie qui embarque un volet apprenant. Alors, dans ces voies de remboursement, et le paysage se complique un peu entre les différentes voies de droit commun et les prises en charge dérogatoires. Pour les industriels aussi, il y a besoin de repères. Il n'y a pas que pour les professionnels et pour les membres. Il y a vraiment un enjeu d'accompagnement et d'explicitation du système français pour toutes les parties prenantes, donc industriels, professionnels et aussi patients, pour savoir d'entrée de jeu et donner la visibilité sur les voies possibles en fonction du type de technologie et sur les critères d'éligibilité spécifiques. C'est-à-dire que maintenant, on a plusieurs voies dérogatoires et plusieurs possibilités de prise en charge de droit commun, également des technologies qui sont modulaires avec différentes briques fonctionnelles. Potentiellement, elles relèvent de différents guichets et ça se complique beaucoup. Donc il y a un gros besoin autour de ces technologies d'accompagnement de l'écosystème. Un des premiers points de ma présentation, c'était qu'on n'évalue pas tout. Et une de nos préoccupations, c'est de savoir comment, maintenant, au-delà de ce qu'on évalue, on peut éclairer les choix des utilisateurs sur ce qui n'est pas évalué par la HAS. Alors, je disais il y a quelques instants qu'il n'y avait pas du tout de cadre pour l'intelligence artificielle, mais ce cadre est maintenant en train de se construire. Donc ces éléments-là vont aussi permettre de guider les choix, et notamment le projet de règlement qui est lié à Acte. Donc voilà, un cadre se construit. Nous, on a eu besoin de l'anticiper pour se préparer à nos évaluations, mais tout ce qui se construit va forcément aider à l'adoption et à éclairer les choix. Alors, dans cette dans ce volet de comment éclairer les choix, il y a toute la brique énorme où il y a un vivier de technologie et la présentation précédente a illustré le champ des possibles autour des dispositifs médicaux qui sont utilisés par les professionnels de santé. Donc tout ce que nous n'évaluons pas, qu'il s'agisse d'aide au dépistage, d'aide au diagnostic, d'aide à la décision médicale ou d'aide à la décision thérapeutique. Donc on peut se poser la question, et on se l'est posé, de ce qui est évalué et ce qui n'est pas évalué, mais quel est l'objectif de cette évaluation? Nous, quand on évalue, pour l'instant, c'est dans une perspective de financement individualisé de la technologie sur le plan national. Donc, si une évaluation doit se mettre en place, pour quel objectif? Et du coup, une réflexion de ce qui devrait être évalué, pour quel objectif, par qui et comment? Est-ce que c'est une évaluation sur le plan national ou est-ce qu'il faut favoriser les évaluations locales? Donc, il y a tout un tas de questionnements qu'on a initiés autour de ça, avec un vrai besoin d'aide au choix dans la sélection. Dans ce périmètre des dispositifs médicaux à usage professionnel, il y a quand même des sortes d'évaluations, même si je vous l'ai dit, il n'y a pas d'évaluation produit par produit. L'évaluation des actes professionnels donne déjà des éléments pour éclairer les choix. Les demandeurs possibles jusqu'à présent étaient l'assurance maladie, le ministère, les CNP, les associations de patients, mais pas les industriels. Donc cela va changer très probablement bientôt avec la loi de finances pour 2024 en discussion. Donc potentiellement, sur cet axe-là, il y a un levier d'amélioration puisque les industriels pourront bientôt demander des évaluations d'actes professionnels pour les technologies pour lesquelles il n'y a pas d'actes existants ou pour lesquelles les actes existants doivent être modifiés et ne sont pas adaptés parce qu'ils ne sont pas adaptés. On peut également, dans le cadre de saisine, nous, HAS, produire des référentiels par catégorie de produits. Donc c'est le cas c'est dans nos missions pour les logiciels d'aide à la prescription, d'aide à la dispensation. On a produit récemment également un référentiel pour des systèmes d'aide à la décision vaccinale ou d'aide à la décision en antibiothérapie. Mais voilà, du coup, là, sur ces sujets-là, il n'y a aucun caractère systématique. On travaille sur saisine. Et puis également, dans les bonnes pratiques professionnelles, et c'est un volet très important des travaux de la HAS, on va questionner spécifiquement désormais les sujets d'utilisation de e-santé et en particulier de télésanté pour mettre en lumière les volets dans les travaux de recommandation et de parcours de soins, ce que peuvent apporter ces technologies numériques. Donc tout ça n'est pas de l'évaluation de chacune des technologies, mais des briques qui permettent aussi d'éclairer les choix. Donc sur cette diapositive, je n'ai mis que quelques exemples de ce qu'on vise spécifiquement dans la réflexion qu'on a mise en place pour savoir si on devait, quel cadre on pouvait mettre en place autour de ce qu'on n'évalue pas et des dispositifs médicaux, dans les dispositifs médicaux à usage professionnel. Je pense que ça rejoint les premiers exemples qu'Erik a présentés tout à l'heure. Donc on peut avoir des sujets autour de l'identification et la lecture de radiologie pour l'identification des fractures ou de nodules pulmonaires sur une radiographie. Il y a également tous les sujets de pré-tri en cytométrie de flux pour d'autres usages, de diagnostic d'arythmie à partir de CG en cardiologie. Il y a aussi le sujet des dispositifs, des jumeaux numériques. En fait, la liste est bien longue, mais l'objectif est de montrer la très grande hétérogénéité des technologies visées. Donc pour ce qu'on n'évalue pas, on a initié une réflexion en 2022 à partir d'une saisine de la direction de la sécurité sociale, donc le ministère, avec comme prisme retenu pour nous, non pas de définir d'emblée un nouveau cadre d'évaluation systématique, mais de voir comment on pouvait aider à contribuer à construire ce cadre de confiance. Restons très humbles, je pense qu'on a besoin de tout le monde pour développer la confiance autour de ces technologies numériques. Donc on a impliqué dans le cadre de ces travaux tout l'écosystème, à la fois les organisations professionnelles, le ministère, l'assurance maladie et des experts tels que nos collègues de l'INRIA et autres, notamment de la CNIL, pour savoir en fait, quel était l'état de l'art déjà sur l'utilisation et l'intégration dans la pratique de ces outils numériques, notamment ceux embarquant de l'intelligence artificielle. Les initiatives également mises en place à l'international par les agences d'évaluation pour se nourrir des expériences de nos collègues. et dans un objectif de ne pas freiner l'innovation, mais de mettre en place des briques qui permettent d'éclairer les choix. Alors on a fait en fait un état des lieux qui visait à savoir quels étaient les freins en fait dans l'utilisation des technologies avec l'intelligence artificielle. Et les freins sont notamment liés aux performances variables des technologies. Donc ça, c'est ce qui est ressorti de la revue bibliographique et des éléments qui nous ont été transmis par les personnes auditionnées, les entités auditionnées. Les potentiels différents niveaux de risque, fonction de la finalité d'usage, et le fait qu'ils intègrent ou non de l'apprentissage automatique, et donc lever le voile en fait sur le type de technologie qui est embarqué dans les technologies qui sont disponibles et proposées sur le marché. Le besoin d'études, également un frein identifié dans cette synthèse, cet état des lieux, donc le besoin de mettre en évidence l'intérêt et notamment l'intérêt comparatif des différentes technologies proposées. Ce qui est ressorti également, c'est qu'il y avait peu d'évaluation de ce type de technologie par nos collègues, nous-mêmes et nos collègues qui sont en charge de l'évaluation des technologies de santé, mais des premiers développements de cadres d'évaluation ou d'outils d'évaluation. Ce qui est ressorti également, c'est que la majorité des organisations professionnelles interrogées souhaitaient qu'on les aide, en fait, qu'on s'empare du sujet sous une forme ou sous une autre, et ils avaient des propositions différentes et un niveau de gradation d'intervention de la HAS différent en fonction en fonction de leur propre avancement aussi sur cette réflexion. Certaines organisations professionnelles ayant elles-mêmes mis en place des outils pour éclairer leur propre choix. Alors, on a choisi de mettre en place un premier cadre de référence pour éclairer les choix. Et on a choisi de faire un outil d'emblée généraliste qui s'appelle un guide d'aide au choix, que je résumerai en les vraies bonnes questions à se poser quand un établissement ou un professionnel veut s'équiper ou veut choisir dans une offre parfois large. Donc la cible, ce sont les professionnels ou les groupes d'achat hospitaliers ou les établissements, avec dans ce guide 4 objectifs qui sont visés. Donc les vraies bonnes questions à se poser pour l'achat, pour choisir un dispositif médical à usage professionnel le plus pertinent en fonction des besoins du professionnel ou de l'établissement, de donner des éléments de réflexion. Donc on pose des questions et on aiguille sur les sources de données possibles pour avoir des réponses, mais il n'y a évidemment dans ce guide très généraliste pas de réponses spécifiques produites, simplement des clés pour obtenir des réponses. Le troisième objectif qu'on vise, c'est au travers de ces questionnements qu'on suggère aux professionnels, de permettre aux entreprises d'apporter une information claire et de la transparence sur leurs produits. A déjà été évoqué tout à l'heure le besoin de faire connaître en fait les données et de donner de l'information sur le niveau de démonstration de l'intérêt. Et bien ça, c'est un enjeu. Et du coup, dans ce guide, voilà, via ce guide, on espère que les industriels pourront se préparer à fournir cette information aux professionnels qui leur demandent de la transparence. Et donc l'objectif, c'était de faire aussi un guide généraliste et accessible pour tous avec 10 questions que chacun est libre de s'emparer librement en fonction de ses besoins. Et justement, en parlant de besoins, donc on part dans ce questionnement sur une première brique de questions qui concerne les besoins. Ensuite, du coup, on enchaîne sur des questions spécifiques qui permettent d'avoir des détails et de comprendre ce qu'est la technologie proposée ou l'offre technologique qui est disponible. Dans les briques de questions, évidemment, on pose la question des éléments de preuve disponibles et des conséquences à la fois organisationnelles et économiques que générerait l'introduction de la technologie. Et puis également quelques questions pour se préparer en amont de l'intégration et donc en amont du choix à bien introduire cette technologie dans l'arsenal du professionnel ou de l'équipe. Alors, c'est une démarche pas à pas. On a commencé par ce guide généraliste. On sait que c'est pas une fin en soi pour répondre à la question de comment guider les usages. Et on compte travailler donc dans les mois qui viennent, après cette synthèse et ce premier guide d'aide au choix, sur les différentes pistes explorées par les différentes spécialités qui ont répondu à nos sollicitations avec 2 pistes principales, soit la production d'autres guides à destination des professionnels ou des établissements, avec un axe qui a été demandé par les experts mobilisés sur les premiers travaux, qui serait plutôt sous l'angle de l'analyse d'impact budgétaire, donc à voir pour favoriser la mise en place de telles évaluations au niveau local, avec une prise en compte de l'écosystème local. La production également d'autres outils socles d'évaluation et éventuellement la mise en place de démarches collaboratives avec les CNP professionnels ou des dispositifs volontaires de labellisation équivalents, la production de référentiels d'évaluation ou d'autres référentiels d'évaluation, pourquoi pas. L'assurance maladie, dans son dernier rapport chargé produit, flèche aussi des pistes. Donc tout ça, ce sont des axes qu'on travaille, qui sont, du coup, si on regarde les propositions de l'assurance maladie, qui sont liées aussi à des nouvelles pistes de financement de ces technologies qui, pour l'instant, pour certaines, n'ont pas de cadre de remboursement dédié. Donc tout ça est en phase d'exploration et on est loin d'avoir fait le tour de la question sur ce sujet numérique qui est en émulation. Il y a la question de l'IA générative qui a été posée tout à l'heure. C'est un sujet dont très probablement on va s'emparer rapidement, qui pour l'instant n'a pas été traité, mais je pense que très rapidement, dans les usages des professionnels, nous allons devoir faire un accompagnement et guider aussi les usages de cette IA générative qui va se retrouver dans des outils spécialisés, mais également il y a la question de l'IA générative dans non spécialistes, dans les usages par les professionnels pour avoir des réponses, éventuellement trouver les recommandations existantes, etc. etc. Donc c'est un vrai enjeu autour de l'IA générative. Voilà, je vous remercie.
Thank you very much, Corinne. We have a little bit of time for questions. Please feel free to ask these in English or French, as you prefer.
Once again, I will begin en français, peut-être. Merci pour cette présentation. En tant qu'agence de HTA, pour les médicaments et même, j'imagine, pour les dispositifs médicaux, vous faites partie d'un réseau maintenant depuis longtemps des agences européennes, et on sait qu'en 2025, il va y avoir cette nouvelle étape dans la convergence européenne pour une évaluation commune des médicaments. Est-ce que, en ce qui concerne tous ces nouveaux types de produits, la France, comme les autres pays, chacun fait encore son petit modèle tout seul, ou est-ce que, pour ne pas reproduire ces divergences, vous commencez d'ores et déjà à avoir au moins des échanges, voire un partenariat sur ces questions-là?
Alors, effectivement, dans le cadre de la mise en place du règlement HTA, la priorité est donnée aux médicaments, mais il y a déjà des discussions et des premiers échanges qui sont mis en place sur les dispositifs médicaux de manière générale. Le sujet numérique va probablement être abordé, à voir si c'est dans le cadre d'une démarche volontaire, etc. Mais la discussion est sur la table. Et par ailleurs, en tant qu'HAS, je participe moi-même à des travaux dans le cadre de task force européenne pour voir comment justement on peut à la fois expliquer nos critères d'évaluation, parce que c'est une difficulté d'un pays à l'autre, et on parlait de l'exemple des DIGA, voilà, ne serait-ce que savoir ce qui rentre dans le périmètre de chaque agence et ce qui peut faire l'objet d'évaluation, c'est déjà un sujet. Le deuxième sujet, c'est de savoir quelles sont les exigences de chacun, et puis je pense que le troisième niveau, ce sera de savoir ce qu'on peut mutualiser. Donc tout ça, en fait, ça fait partie d'interactions qu'on a avec nos homologues européens, à la fois dans le cadre de la mise en place du règlement HTA, et aussi dans le cadre de task force auquel on participe bien volontiers pour faire avancer la question de la convergence européenne, je vais le dire comme ça.
Merci beaucoup pour cette présentation. J'ai une question sur plus l'accès à ces solutions pour les utilisateurs finaux, pour les patients, et comment les aider aujourd'hui dans le cadre français. Je pourrais vous donner, moi, les exemples, parce que je travaille sur l'Allemagne, donc je connais bien la DIGA, pour se repérer dans cette multitude de solutions dont on a parlé, qui sont justement pas toutes évaluées. Et même celles qui sont évaluées, c'est quand même pas simple.
Alors, pour ce qui est évalué, c'est assez simple parce qu'on en a très peu évalué. Mais en revanche, les listes de remboursement donnent accès à cette information. Après, il y a certainement quelque chose à construire avec le référencement dans mon espace santé qui est en place. Donc, mon espace santé qui ne vise pas que des dispositifs médicaux, mais qui vise des applications en santé, donc avec des finalités d'utilisation différentes. Donc, vous avez raison, il y a un vrai besoin d'accès à l'information. J'ai parlé de ce qu'on mettait en place pour éclairer les choix des professionnels, mais éclairer les choix des patients, ça passe aussi par l'accès à l'information et de même type en fait que celle dont ont besoin les professionnels, mais quand il s'agit de technologies qui visent les patients. Voilà, j'ai pas de réponse puisqu'il y a les listes de remboursement pour ce qu'on évalue. Je pense qu'il y a des interactions et on a déjà eu quelques échanges avec l'équipe de la délégation numérique en santé pour voir comment se servir du référencement dans mon espace santé pour développer l'accès à l'information pour les patients. Donc pour l'instant, j'ai pas la solution, mais c'est effectivement au cœur de nos discussions. Le seul élément qu'on a pour l'instant, c'est les travaux antérieurs et les critères de qualité du contenu de l'information. Du coup, qui sert au référencement dans mon espace santé, mais les réponses ne sont pas forcément transparentes pour l'utilisateur. Simplement, pour le référencement, c'est pris en compte.
Bonjour. Merci Madame Collignon pour votre intervention. J'avais une autre question sur justement la partie DM numérique pour les patients. Est-ce que vous devez savoir, je pense, combien il y a de DM numériques qui ont été validés et donc qui peuvent être prescrits par les médecins? Combien il y a de patients du coup qui en bénéficient? Et est-ce qu'il y a ensuite une étude qui mesure tout type de DM numérique pris en charge confondu, l'amélioration de l'observance, ou si c'est à visée thérapeutique ou de iatrogénie qui diminue, j'en sais rien. Est-ce qu'il y a des études qui prouvent hors industriel, c'est-à-dire l'État français ou la HAS, est-ce qu'elle évalue cela?
Alors pour l'instant, la voie de remboursement des DM numériques se met en place. Du coup, on a dans le cadre du guichet numérique qui a été mis en place cette année, la commission a été saisie sur 5 dossiers qui sont des dossiers de télésurveillance médicale. Donc un certain nombre de ces avis sont déjà publics. Dès que le process est terminé, en fait, pour chaque instruction, l'avis est systématiquement public. Donc voilà, à ce jour, 5 technologies, mais exclusivement de la télésurveillance médicale. Donc je pense que ce n'est pas tout à fait le sujet que vous évoquez. Pour le reste, antérieurement, il y a eu une application. Donc, antérieurement à la mise en place de ces textes spécifiques pour le numérique, il y a eu une application dans le cadre de la dépression qui a été évaluée par la CNEDIMS. L'avis a été positif, mais le produit n'est pour l'instant pas inscrit sur la liste de remboursement. C'est un produit qui a fait l'objet d'un service attendu suffisant, avec une amélioration du service attendu de niveau 5, ce qui probablement n'a pas aidé à la négociation tarifaire derrière. Donc ça, c'est lié aux données qui ont été apportées, à la stratégie et à l'indication. Enfin, la CNIL se prononce sur une indication qui est revendiquée par l'industriel et apporte les données. Donc c'est sur cette base que la CNIL s'est prononcée. Donc pour l'instant, c'est vrai qu'on n'a pas pléthore d'applications qui sont sur les listes de remboursement. Et du coup, votre question sur le suivi après. Donc la CNIMS peut demander dans ses évaluations ce qu'on appelle les études post-inscription, mais dont la charge est à l'entreprise. Et par ailleurs, en réponse à votre question, je pense que l'approche peut être aussi d'analyser du coup les résultats et les indicateurs en termes de parcours de soins qui pour l'instant ne visent pas spécifiquement les aspects numériques, mais dans les parcours où on verra l'introduction de technologies numériques, on peut espérer qu'au travers des indicateurs de parcours, on voit des améliorations, par exemple. Donc ça, c'est une possibilité. En entrant dans votre question, c'est une des approches possibles. Et puis, par ailleurs, le législateur a prévu, mais pour l'instant, du coup, on est en train de travailler sur la bonne typologie des indicateurs, pour les technologies qui vont faire l'objet d'une numérique, qui vont faire l'objet d'une inscription en remboursement, la production d'indicateurs, et le législateur a prévu qu'ils soient à la fois individualisés et nationaux. Donc, au travers de cette nouveauté d'indicateurs dans le cadre d'un guichet, peut-être pourrons-nous à terme produire des résultats tels que vous les mentionnez pour voir l'impact qu'ont ces technologies dans l'état de santé ou les organisations. Pour l'instant, on n'arrive pas à... On n'a pas identifié la typologie d'indicateurs et surtout, il nous faut savoir qui va les exploiter. Et du coup, est-ce que c'est l'industriel ou est-ce que c'est l'assurance maladie, par exemple, ou est-ce que c'est d'autres acteurs et qui va produire les résultats pour produire ces indicateurs. Donc, il y a cette notion d'indicateur qui a été prévue par le législateur pour ces technologies numériques. Il nous reste à transposer, en fait, sur le plan pratique, ce que l'on peut mettre en place pour travailler cette notion d'indicateur dans ce nouveau cadre. Pour l'instant, c'est pas en place et on est en train d'y travailler.
Thank you for a great presentation. Sorry, to switch to English. I was wondering, are there any minimum evidence requirements when you file for reimbursement for a digital innovation, or requirements on collecting data during follow-up? Because there might be a risk that in the end, at least also after follow-up, you don't have the evidence, you don't have the indicators yet that allow you to do a reassessment or re-evaluation. So how does that work? Can you expand a bit on that?
We can ask to the company to produce some additional data for reimbursement. So the company can be asked to put a post-listing study in order to, for example, to answer to the question of the real effect in the real life. Mm-hmm. So it can be an issue to deal with your question. It totally depends on the type of product, and it's on the end of the committee to ask or not such post-listing study. There is no systematic rule, it's a case-by-case strategy.
Thank you.
Great, thank you very much, Corinne. I would propose that we go for the coffee break now and then reconvene here in about 20 minutes at 11:15 for the roundtable discussion. Corinne will also join us for this roundtable discussion, so there will be more opportunities to discuss with her then. Thank you. All right, welcome back. For the second part of this morning's session, we planned a roundtable discussion under the very broad theme of challenges and opportunities of digital health technologies. This is deliberately broad because the aim of this discussion is just to bring together different perspectives on digital health technologies. We already heard this morning in the two keynotes from Erik and Corinne. Erik, perhaps coming from a more academic perspective, of course, as a researcher working on the implementation of digital health technology. There's of course an important practical element there, but Erik is also particularly an expert on methods needed for digital health technologies, and Corinne's perspective is of course perhaps a little bit more oriented towards the policy side of things and trying to develop the adequate policies. Both of them will join us for this discussion, but we also have the pleasure of 3 additional speakers that will give us their views on digital health technologies. I will introduce these turn by turn. And I want to start with my colleague Pierre Levy, who's here on my right. Pierre is a Maître de conférence here at Dauphine University, and in fact he has been at Dauphine for more than 35 years. He is a health economist and who is working on the evaluation of health technologies and in particular drugs, where he has extensive experience. He's also in charge of the Executive Master Program on Economic Evaluation and Market Access of Health Technologies, and he's been director of this Master Program for more than 20 years, so he has been he's played a very important role in the work that's being done, both in research and teaching on economic evaluation of health technologies here at Dauphine. So Pierre, Erik already gave us his view this morning about some of the challenges that digital health technologies pose for the traditional methods that we use to try and assess the value of health technologies. You've worked extensively on evaluation primarily of drugs. So what are your thoughts on this? To what extent can we evaluate digital health technologies as we evaluate other health technologies, or, and use our established arsenal of methods, or to what extent are we dealing with a completely new type of technology that also requires from us as health economists to reconsider our approach and potentially develop new methods?
Thank you, Peter. I will try to speak in English for our audience. So I would give a balanced answer to this question, but perhaps before elaborating on this, I think that we need to be clear on what exactly we are talking about, because there are so many different things, as we saw earlier this morning, from e-health, digital health technologies, and so on, and telemedicine, for instance, which is important in France. Because there are huge differences between what is related to wellness, for instance, and support, such as lifestyle apps, on the one hand, and on the other hand, what we usually call digital therapeutics, which are able to deliver clinical interventions, for instance, via a software to treat, prevent, or manage disease for patients. And viewed from the drug perspective, I would say, there is a strong difference between these two types of digital technologies, because depending on the intent, on the goal of these tools, the second, I would say, the digital therapeutics are associated with much more risks for patients. And so this is why we are still, or we will require much more information about clinical evaluation, regulatory oversight, and probably real-world evidence requirements, as was mentioned earlier. So here, to compare to drugs, I think that I have to limit my what I will say to digital therapeutics, because there is here a clear intent to treat patients as with drugs. And from that point of view, I would say partly there are some fundamentals which are quite similar to drugs, or I would say standard medical devices, in the sense that first we need to have a regulatory phase, which is based for drugs on the FDA approval or EMA approval and marketing authorization, or for medical devices, the CE mark. And this applies to digital therapeutics. And the second phase, which was mentioned earlier this morning, is the health technology assessment, the HTA assessment, which is a process which is the basis for deciding on whether we should reimburse and at what price any technology, and which is based on value assessment. The problem is that devil is in the details, and then I would say talking about value assessment means that we will have here to consider mainly differently the digital therapeutics than drugs or even traditional medical devices, because usually what we find in an HTA framework is the need to document some clinical evidence, some clinical assessment, generally an economic evaluation, and more rarely some organizational impact. for any of these dimensions, I think that for digital therapeutics, we can't just copy-paste what we already have for drugs and devices, because there are some specificities, there are some differences which were mentioned this morning with digital therapeutics, so that we have to probably define a new framework and a new pathway, I would say. I will just mention briefly some points which seems to me important here. First, regarding comparators. We usually want some comparative assessment, and the problem here is that usually digital therapeutics will have to be compared to non-digital technologies. And there will be then a problem, because the evidence base for this comparison will be completely different, due also to the second aspect, which is the point that digital therapeutics will quickly evolve over time. So the evidence base is never, I would say, fixed, and it's much more difficult to have some robust estimates, which is usually very important for HTA agencies, because what we want is to reduce the uncertainty around the decision for pricing and reimbursement. So this is a second problem, how to manage this. It was mentioned with this living HTA, but we still need to work on that. The third problem, I would say, is that with digital therapeutics, we try usually to modify patient behavior, and this is important because it also means that we need patient involvement, and so this means that in the assessment we should also take into consideration patient time and patient costs, which are important in any economic evaluation, which is rarely the case for drugs, for instance. And finally, the last point I would like to mention regarding what's specific to digital therapeutics is the fact that it will usually have an impact on the organization of care. We could say already the case for some drugs, for instance, when you have oral chemotherapies or with telemedicine, but it's partly a digital solution. And so even if it may be taken into account, it's mentioned in the HTA frameworks that for drugs and devices we could take this into consideration. It's rarely the case. So this means that the conventional, the standard framework for assessment of drugs and medical devices is not relevant and may miss this dimension, which is very important. And as we saw earlier with the presentation of Madame Collignon, is that if we take France as an example, we could say, okay, we have, fortunately, the HAS has already defined a framework for assessing the impact on the organization of care of any healthcare technologies, including digital therapeutics. But we know that the problem is that we can only have a qualitative assessment, and so it's very difficult to quantify this. And probably there is something which is missing here to have a complete evaluation, because in the end what we want is a quantitative assessment. And I must say that related to France, one of the problems I can see here, for example, is the fact that usually digital therapeutics will not be treated or will not have to perform an economic evaluation. They will be below the threshold that is usually used to define which technology has to be estimated from the economic perspective. And for sure, we can say, oh, it's unfortunate because the economic value of any technology is important. Well, in France we have some problems to exactly define in which way, but we try to do so. And I must say that one thing which is somewhat weird to me is that the HAS try to say, okay, one experiment we could have, and I think you did not mention this earlier, is that we could try to propose to manufacturers, to the industry, to assess the budget impact associated with the change in the organization of care, only if it's associated with cost savings. So, as an economist, I would say, I don't think this is the appropriate way, because here, I understand you try to have some economic assessment, but it's not cost effectiveness. So if you only try to measure the budget impact insofar as it is related to cost savings, this means that there could be a problem, because you will only, I would say, give a premium to digital therapeutics insofar as they are associated with cost savings. And this would not be related to the clinical benefits. And usually we perform cost effectiveness studies because we want to measure the balance between clinical benefits and the extra costs. So I'm not so sure this is the appropriate way, but we could discuss this later. So to answer to your question, I would say there are challenges, for sure, especially regarding the appropriate framework and methods to assess this specific type of technologies. But we see that there is a willingness from HTA perspective, from HTA agencies to develop this, to define the appropriate framework. So we can be confident that in the future we will have more appropriate, I would say, pathways and framework. So we may be optimistic from that point of view. And I would like to add a final word as an economist to say that one other aspect which was not mentioned, but perhaps I'm sure Madame Servier will talk about that, is the specificity of digital therapeutics from an industrial perspective. Because what we see is that as they are usually not standalones, but solutions to be used in combination with drugs, the big pharma is interested in initiating partnership or different types of alliance with manufacturers of those specific type of products. And it's quite new because usually there is no relationship between the pharma industry and medical device manufacturers. So it will be interesting to see to what extent it will reshape the healthcare sector in the future. Thank you.
Thank you, Pierre. This, I think, is a good point to introduce Marion Servier. Marion is the global business lead for digital health at Sanofi, and I think it's great to have you here with us today, because we just heard from Pierre and earlier from Erik that indeed digital health poses some challenges on how we think about evaluating these technologies. Corinne Collignon talked about efforts by the regulatory agencies to try and provide guidance for businesses on how to navigate the process of making their technologies available. So I think it's great that you're here with us today, so that we can hear your thoughts based on your experience working with digital health businesses in Europe and internationally on these aspects.
Thank you very much, and good morning, everyone. So I'm today in an innovation team. hope it will work better. So I'm in an innovation team within Sanofi General Medicine Business, what's called Digital Healthcare. And within this team, I'm responsible of business and operations, especially focused on Western Europe and China. And concretely, what I'm doing is to design a user experience answering to specific unmet needs for patients, but also launching concretely digital solutions within the markets. Today, I will quickly explain what the opportunities that we are looking, give you a concrete example of some solutions that we launched in Germany through DIGA, but also GBA pathway. And I would like also to put in perspective some barriers, some remaining barriers that we are facing in terms of value and access for us, but also for the patient and for the healthcare professionals. So within my team, we have the vision, and we are convinced that digital healthcare journey should take more of a whole person approach, especially in case of chronic conditions. And I think we have a consensus here that we need to go beyond drug, we need to go beyond treatment choices to achieve health and economic outcomes. To do that, we are in the beginning of the value chain, I would say, designing experiences to improve user engagement within the digital solution. And so we are combining technology assets that are collecting patient-generated data with behavioral science and with user experience to personalize the care. In Germany, for instance, we have proven with a randomized control trial that personalized remote monitoring of heart failure patients is improving patient life by decreasing their time in the hospitals, 6.4 days versus normal care, and also by improving the health with a reduction of roughly 30% of all-cause mortality versus standard care. This leads also to these health economic outcomes, and improvement of quality of life for the patient will also lead to health economic outcomes, because concretely, reduction of stays in hospitals means improvement of economic outcomes. So we see a lot of opportunities for the patient, for the healthcare professionals, for the payers in digital healthcare solutions. These tools are supporting patients to achieve self-management behaviors, but also to have personalized care thanks to data, and ultimately improve health and economic outcomes. But despite all these opportunities, we still see some barriers in terms of adoption of the solution, access to the solution, and framework. And I will try to detail some of them and give you some examples. So I won't go into details into all the medical economic challenges that we are facing to give access to this solution to the patient, because I'm not a market access expert and I'm not a doctor. But in business and operations, we still see some challenges. The first one I would say is around the who. Who are the actors that could be interested to access, to use, to prescribe this solution? I'm talking to the healthcare professionals, but I'm also talking about the end user, the patient, or what could be a user if it's not defined as a patient, if it's not a digital therapeutics. Today, all users are not trained to the arrival and to the use of these new digital solutions. It's a challenge, but also they don't know how to navigate and how to select the right digital solution for them. In Germany, it's up to the tech player or the person who will distribute the digital solution to reach, to convince, to train all users, all healthcare professionals to this kind of solution. It's also an issue when we are talking about how to recruit also our investigators for clinical trials, because this market is super nascent and it's still a challenge to do our clinical trial studies. The second aspect of the barrier will be around the framework. The framework is complex compared to drugs, established framework. In digital healthcare, the framework is still complex, and from an end-to-end of the value chain, we still see challenges. For instance, if we are talking about the beginning of the change, when we are thinking about the design of the solution, it's difficult for industries, for medtech, for tech player, to know what will be the necessary features that will be valued for the reimbursement. We often don't know how the solution will be brought into the market. We don't know how the solution will be reimbursed into the market. And so the environment, it's complex. In addition, the environment is evolving, and to improve the user experience and the customer experience within a solution, we are taking into consideration a lot of factors. And sometimes we think about super important features, but that are not valued. For instance, I would say mental workload, or if we are talking about CSR, reduction of CO2 emissions. These new features that are important to think before building the product, it's difficult to anticipate for us. The second part will be for the user, healthcare professional, patient. It's super complicated to have access to these kind of solutions and to navigate into it. I will give you a quick example for DIGA. In Germany, when you've done your medical study, when you have been reimbursed through DIGA pathway, when you have been prescribed, it's still a huge burden for the patient to access to the solution. And we know that half of the patient with a prescription don't get to the end of what we call the onboarding process into the solution. Why? Because it's a true complexity, concretely, to get the code to access to the solution. The example is the patient needs to send by post the prescription, the paper prescription, to the health insurer, the sick fund, and then the sick fund will edit a 16-digit code sent back by post to the patient for the patient to enter the code in the application. We're losing half of the people there. So there is, in terms of access, we can see several angles as well. Last piece, I would say it's in terms of data. We mentioned it, all of us mentioned it. It's still complex to have access to data. The framework is not clear. It takes a lot of time. The framework is fragmented. And so all in all, we are losing the value of the data that we can use to either explain the benefit of the solution, either doing some benchmarking, comparing other solutions, either doing some improvement within the solution, and so on. So my key takeaways, so for me and for my team, digitally enabled patient-centered monitoring system may help people to live their life to the fullest. However, the market is nascent, the market is evolving quickly, and it's difficult for pharma industries to navigate into it compared to traditional established drugs. So we could ask the following questions. In my mind, 3, how to support HCPs to improve adoptions and access to this solution, how to simplify access for any end user, and how to create an agile framework for technology assessment to keep the speed of the rapid evolution of these technologies while still retaining the value of patient-generated data. Thank you.
Thank you, Marion. This was very interesting, and I have to apologize. I had to laugh at some point there because what you described with sending codes around per mail, that is a very German thing. I think I can safely say this as a German. This is, I think, probably the most German thing I heard in the last year or so. But I think it very nicely demonstrates some of the challenges that that we face in implementing digital health technologies. I think this also connects to something that Erik said this morning, that that even when these technologies are implemented, the value that we gain by these technologies really depends that we actually have an idea and the necessary policies in place to really try and I don't want to say benefit from these technologies, but realize the potential benefit that they might pose. I think you gave a very good example with the fast MRI. So this then brings me to my third speaker, which is Erik Sutherland, who is a senior health economist at the OECD. Erik has a background in statistics, but he's, well, not but perhaps of this, he's very passionate about data. He previously was working as Executive Director for Data Strategy at the Canadian Institute for Health Information. He was also working in a similar role for the Public Health Agency of Canada, working on health data. And the OECD very recently published their report, Health at a Glance, 2023, which also included a chapter on digital health in which Erik and his team assessed digital health readiness of the OECD member states. So I want to ask you, Erik, what's your takeaway from this? To what extent do you think the policies that we have in place currently are fit for purpose to make sure that we actually benefit from the implementation of these technologies?
So thank you, Peter. I could give an answer very, very quickly. They're not ready. But probably makes sense to add some color onto that comment. So for context, so I work at the OECD, which is about 15 minutes down the road walking from here. I sit in the health division, and I spend a disproportionate amount of my time working with other directorates at the OECD who are focused on areas of health data. They focus on data governance, privacy, security, and everyone's favorite new topic of artificial intelligence. So I get to work on all of those areas as it intersects with health across the OECD countries. So as you can imagine, I don't get a lot of sleep. But it's actually one of the most interesting and innovative areas that I could ever imagine working in. As Peter said, we just published our Health at a Glance. I'll summarize the chapter for you in a couple of sentences. One, digital transformation is an emerging determinant of health. Countries that are more digitized will achieve better health outcomes. So we don't yet have the evidence associated with that, hence why I'm very interested in having a conversation with my namesake. But it is that the evidence is mounting, and I think that it's really important that we lean into that. The second thing that I note, which also very much reflected on what we've already heard, we aren't very good at measuring the progress and the value of digital interventions. And what measures we have show that we're not doing very well. So that summarizes the 30 pages of Health at a Glance for you. But there's a lot of work for us to actually do that work going forward, because in order to realize digital as a determinant of health, we need to ensure that the data that we have are connected, the technologies are connected, the systems are interoperable, such that the data maintains its meaning, and that the data are available, as we've heard time and time again. And frankly, we live in a world where 30% of the global health, 30% of the global data assets are in health. Health uses 3% of our data assets for decision-making purposes. That means we do not use 29% of global data assets to generate value. That feels irresponsible. That feels like we're letting down the planet in terms of our ability to actually generate benefits from science, to drive better health outcomes for people. And so that's really where I think we need to have policy structures that actually enable and unlock that value as a whole. The part of the challenge that we've had in the policy space, if I can put it this way, is that for too long, this world of digital health has felt too technical. Oh, we'll worry, the IT guys will worry about it, they'll take care of everything. Us policymakers, we can't understand it. It looks like magic to me. We have to overcome that barrier. Digital health is about people. Policymakers are incented, should be driving benefits for people. We have to make it easy for those policymakers to design policies that actually benefit people. And I'll talk about how I think, to expand on where policies are failing us, I think it's failing us in at minimum 3 important ways. One is that the technology fragmentation that we see across many OECD countries are a direct result of the policy fragmentation or the lack of policies that we've had in this space. I'll give you an example that where I came from in Ontario in Canada. We did a study to map out how long would it take one innovator to get access to one provincial data asset in order for them to be able to drive their innovation to provide services to the public who had consented for their data to be used for that purpose. It took one innovator 18 months, $50,000, 12 approvals, in order to be able to get access to one asset. At scale, when you think about innovation writ large, you are not innovating in that environment. Innovators can't afford that $50,000. They cannot afford those 18 months. And frankly, the public are just feeling let down because this promise of innovation isn't happening for them. And when, frankly, every other aspect of their lives are being digitalized, they see that health is still using fax machines, which incidentally, 75% of the world's faxes are for health purposes. Interesting factoids, just to demonstrate the lack of progress that we have meaningfully made in this space. So from a policy perspective, in terms of the fragmentation that we have, we need to be thinking about how do we reduce the friction, which is frankly what we heard from everybody so far this morning. How do we establish the standards that are in place and govern those standards effectively to make sure that they're implemented and used effectively in the system to enable this interoperable, available data framework that we must have if we want to be working forward. And importantly, we have to do so across organizations. Too often, I think we think if one organization solves it, that's great. But if I build my system to be a square, and my next door neighbor builds a circle, and their next door neighbor builds a triangle, those 3 puzzle pieces don't fit together very well. So we need to be thinking about the data supply chains that underpin our systems. So what are all the connection points that happen, and how do we harmonize policies across our organizations to achieve the ultimate goal, which is better health of individuals? Too often we design our policies with respect to our individual organizations, but not with respect to what the overall process is meant to be to, again, benefit the people that we meant to benefit at the end of the day. So that was one. A second area where I think that we are failing ourselves in policy is we inadvertently incent inaction and inertia. And this is one of the things as I've traveled across Europe in the last year, there is palpable fear around things like the general data protection regulations, the roles of the data protection officers, which, frankly, I feel a massive amount of empathy for data protection officers because they are quite literally in a no-win situation. They're presented with, here's a fantastic innovation, and we just need to get access to data in order for this thing to work. And from their perspective, it's like, well, for me to say yes, unless you have expressed consent from everybody who's involved, which, by the way, at a population level, probably isn't going to happen meaningfully, then they have to make a determination whether or not that innovation is in the public good, to actually use the clause that exists in GDPR for such purposes. The risk for them saying yes is that somebody somewhere may say, no, I disagree with you, and they would actually get slapped with massive fines and repercussions. For the cost of them saying no is none. There is no cost to them saying no. There is no disincentive for them to not enable the value of data being created in and of itself. So we need to be shifting our thinking from a harms-based approach, which is solely focused on the risk of privacy to individuals, to a harms-based approach of, well, what are all the harms that can come out of the action of sharing and mobilizing data and the action of not mobilizing and not sharing data? There are 168,000 people that will die in Europe this year because of medical error. Other studies have shown 30% of medical errors are due to lack of information, which is lack of appropriate timing of the right data in the right place. So if I do the math, and all of this is true, and this may be a stretch, but I think it's not too far away, that means that 50,000 people will die in Europe this year because of poor data infrastructure. That's preventable if we actually do something about it. And I think we have an imperative to incent the saving of people's lives through the effective sharing and use of data while ensuring the appropriate protections in place. But the focus must be on the use of the data and how do I ensure protections are in place, not on how do I protect the data, and once I've protected it, then we'll see how it can be used. It's shifting the focus to use of the data for benefit of humanity. That was the second area. The third area, very much aligned with what we heard this morning, is frankly the lack of measurement that we have in the system, the pervasive lack of measurement. We are neither measuring progress nor are we measuring value. And the funny thing is, I fundamentally believe, to be proven, and frankly, probably going to have a conversation with Erik shortly after this, I believe that data are the only asset that will consistently increase in value. Technology will always depreciate in time because it needs to be upgraded and replaced. People, sadly, will either retire or expire. And so from that perspective, our human workforces will always depreciate in time. The knowledge is leaving the workforce, in particular as the demographic crisis grows and the older parts of our health workforces retire and go away. So we have to unlock the value of our data. So unlocking the value of our data only achieves that outcome if we're able to use it to bend the cost curve of systems. Because, as Erik said earlier on, frankly, all health systems across the OECD, they're all going to go bankrupt in the next 50 years. Like, just say it plainly. They're going to be very uncomfortable decisions about what they will say yes and no to. The only opportunity to bend that exponential curve we sent earlier on is to enable the exponential value we get out of data in order to improve health outcomes. And so that's one of the things that I think we need to spend time on, but that requires measurement and application of the measurement into our systems in and of itself. So ultimately, where I'm coming at from all this is that digital health, as much as it feels kind of technical, overcoming the barriers of incentives and of policy and of measurement, these are all things that are done by humans. This is a human-based challenge to unlock the value from our technology solutions in and of itself. And it is within the grasp of our policymakers in order to make those changes in and of itself. But we need to move from the way we've been thinking about how to implement digital solutions as let's make the paper-based processes that we used to have and let's make them digital. That doesn't work anymore because those processes are linear. If we want to realize exponential value, we have to enable the power of networks. The first fax machine had no value. The second fax machine had limited value. The millionth fax machine had a massive amount of value because you could connect it to almost a million others. How can we ensure that the data that we're creating, the tools that we're creating, are optimally able to scale and are optimally able to be reused? Because frankly, as I've seen across the OECD, we're addicted to pilot projects that cannot scale. And so we need to establish the incentives that enable the scaling of our innovations, the reuse of our innovations, and the active fostering of networks that build greater and stronger networks that are resilient to change, secure against cyber attacks, protect the data, and generate enormous value. And we need to measure that value, and we need to be able to demonstrate that value back to the public. So ultimately, in closing, to reap the benefits of all these digital technologies in a way that drives the equitable outcomes that we're looking for, we need policies that work across data supply chains, across industries, and across borders. We need incentives that minimize harm from the use of digital tools, from the use of the data, and from the non-use of digital tools and the non-use of data. And we need to be measuring the system most effectively in a way that demonstrates progress and value transparently to the public and to our policymakers to be able to march our way to the future that, frankly, I want to live in.
Thank you, Erik. This was very thought-provoking. And I think at this point, we should open the floor to questions or discussions, both among all of us, but also from the audience. I want to start with something because I think you already mentioned that I saw quite a lot of connections between what you said and what we heard from Erik this morning in his keynote. As you said, data policies are fragmented across countries, but also across organizations, and I think perhaps in some sense this was reflected in your keynote this morning, where you showed that the effectiveness of digital technologies really depends a lot on the context in which it is used, and it's really difficult to kind of like make a blanket statement on how well these technologies work. At the same time, we've heard from you about the need and from you about the hope that these technologies can actually save healthcare costs in the healthcare system. And what I'm wondering about is that I would usually expect that that to really realize these cost savings, we need these technologies to scale and to scale up. And to me, it seems that this context dependence is a barrier. And I think this is also what I heard from your statement right now, that you would probably agree with that. So I was wondering whether either of you, or indeed anyone else, has any thoughts on to what extent is this something that we need, this context dependence. To what extent do we need to overcome this by essentially streamlining policies and generally the implementation of these technologies across organizations, or to what extent is this something that we need to work with to try and really tailor the implementation of digital health technologies to the context in which they are being used, in some cases on a hospital by hospital basis, for example?
Thank you. Very, very good question. I think we can definitely make progress there, at least considering the Netherlands. So when you look at digital health innovations that have the aim, or as one of their aims, to improve the organizational processes, this is typically done by one or a few hospitals. So that's not scalable, it's not efficient either. But we also know that if you assess the same tool, for example, within radiology, and you look at the added value for a radiological department, the value does depend on which type of hospital you're looking at. So we have university medical hospitals with a huge amount of experience and the best radiologists in the countries. We also have hospitals that are not involved as much in research, and also hospitals that do not do any research at all, but provide, let's say, the standard care. So the benefits of this technology, we found, is really different for the different hospitals. It depends, amongst others, on the expertise that you already have within your hospital. So I think that there's no single value for tools in that context, but the efforts on research in this field should really come from groups of hospitals with the same context, within the same context. And that's something we can work on and we should work on. So there we should really do these kind of studies in a collaboration with, for example, only university hospitals or other hospitals to make sure that each and every hospital doesn't need to repeat this analysis themselves, and they actually share the results and they learn from each other, but they learn from their peers in the exact same context, because these results will not be generalizable across all hospitals.
I think that's a great, great example, and I think it's applicable to many other areas, and we heard about the concerns around AI earlier on. One of the things, the language in the US White House had an executive order 2 weeks ago on AI, and I thought one of the interesting bits of language they had in there was, part of their directive was to work on removing the unhelpful and unnecessary barriers to the use of responsible AI with a focus in human-facing areas such as healthcare. And so I think it's recognition that what we have done is we've created these unnecessary and unhelpful barriers. We have the ability to address them, but we do need to do so responsibly, which is we need to make sure that the context is appropriate. And when it comes to training AI, if you train AI, frankly, you're training AI on the data you have. So if you have data about a particular population, a particular area, that algorithm may not scale well to other areas because, frankly, the demographics may be different. But the methods that you use for training the AI may be appropriate. So that's one of the things when thinking about scaling AI, doing so blindly is equally risky and possibly to create harm. Now, I'll actually ask a provocative question and just leave it out there dangling, is from an ethical perspective, in order for a small rural hospital to build AI on their patient population, frankly, maybe well beyond their capabilities. And so is it unethical to develop AI in large urban rich centers that is unable to be able to scale to a rural hospital? Or is it the appropriate method to have the ability for the rural hospital to use that algorithm even though it only has 80% effectiveness? That's going to be an interesting ethical question that I do not yet have an answer to.
So perhaps related to this, another thing I was wondering, and perhaps it would be interesting to specifically hear from Marion about this, is that from my own experience in health economics and working in health economics, it is often the case that technologies that we hope that are sometimes promised to save costs end up being actually more expensive in the long run. What I'm thinking of specifically here is prevention as a very famous example. Prevention in many cases is more costly than the cure, but at least among health economists, it's also typically accepted that is not necessarily a problem in itself, because there is still value that's being created because people do actually like not becoming sick. And I think one of the things that we heard this morning is also the focus on the user experience and the benefit to the user. So this again connects to the fast MRI example that Erik gave, that of course for a hospital the question is, what do we actually do with the gain that now we can do an MRI in a quarter of the time that it previously took? But from a patient perspective, I can very definitely see a value of having, to spend only a quarter of my time in an MRI machine, which is not a very pleasant experience. So I was wondering, to what extent is the focus on cost savings really the right angle from which we should consider digital health technologies, and what role should the patient experience play here? So perhaps, Marion, you could start with that, but of course I think that's a question that perhaps is of more wider interest.
So the medico-economic evaluation and what we intend at the end is to have value-based care. It's something which is super important within this context where expenditures, costs are increasing and the model is not sustainable. So we don't have a choice that to move on with more value-based care and visibility on what is the performance of a digital healthcare solution and what is the performance of an intervention and its economical impact. But of course, it's super important as well, as I mentioned, some barriers are still there to take into consideration the entire quality of life, the entire improvement for the patient. And it's up to the startup, the industry, to think about this user experience and how to improve the patient journey, how to improve the healthcare journey in general. But not all of the improvement that we will do are valued. And this is something that it's sometimes hurting with the innovation and decreasing it.
So I agree. Looking at economic valuation is not the only thing. Okay, it's having a fit. I would just look at the quintuple aim. Quintuple aim, patient-reported outcome, patient-reported experience, equitable outcome, cost. And one of the things we fail to measure a lot is provider experience, because when we implement these new innovations, frankly, there is massive amount of burnout that's happening in North America because of innovations from new digital tools that were not properly integrated into the process that, frankly, just made the doctors really angry at the system, don't understand why they're doing it, don't see any value of it, and frankly, so the data they actually put into it, they actually don't care. And so the value of the tool ends up getting negated, so you create this negative spiral of value. So I think that we have to think about all aspects of that quintuple aim and how do we elevate all of them, or more to the point, as we implement innovations, we're not decreasing any of them while we're optimizing appropriately across them.
Just a few words on the HS point of view about that. It is essential to have patient-reported outcomes and also professional user experiences. What we have to deal with specifically with this kind of data is the quality of the data that the company can submit to us. So there is a huge range of improvement in the quality of data for such outcomes that are crucial in our assessment and to highlight the potential of such technology. So there is a huge effort to do in order to make possible to use such data from user experience, and I would say that it is a big challenge, but it is an important one.
Sorry, but I think I would give a dissenting view because, okay, PROs, patient experience, it's very good. But in the end, I would say as a proxy payer, we don't pay for comfort. And we know in France, but also in other countries, that in the end, quality of life, PROs, and so on is not so much important. Usually what we want is, and I must say, it's unclear to me what do we expect from that point of view from digital technologies. Do we expect improving clinical benefit, cost savings, or even both? Because if it's the case, I think we will be disappointed in many cases. So, and I think that well, expecting having huge cost savings in our healthcare systems due to the intensive use of those digital solutions is a dream. I'm not so sure it will be the case, though. Probably we should focus on clinical benefits, but probably also what is called non-clinical benefits, but I'm not so sure that someone would pay for those non-clinical benefits.
Final intervention, I think.
Just to react, I think there is systematically a discussion to have whether we are talking about the benefit and the added value. So regarding two technologies having the same performance and the same clinical result, it is assumed in the French system that the added value can be regarding the quality of life of the patient. So we do not have a lot of experience of technology that have demonstrated this type of added value, but it is possible, and probably it is important for digital devices that could afford such improvement in the quality of life, but not with a decrease of the quality of their clinical status.
Thank you. As you see, we've hit upon some interesting, I don't want to call them disagreements, but different perspectives, and it would be great to keep the discussion going, but unfortunately, we've run out of time at this point, so I'll have to close the session here. We have posters outside, prepared by some of our PhD students, that are related to artificial intelligence and machine learning. I'm sure there's some very interesting research that's being reported there, so please feel free to have a look. And I also want to vote, because there's going to be a best
the prize
paper.
of the best poster will be delivered tonight. Yeah.
Yes. So please feel free to vote for your favorite poster. And this afternoon we have another session on on blockchain and decentralized finance. At this point, I want to thank all the speakers here, and of course, I want to thank you for attending what I thought was a very stimulating session.